Bismillahirrahmanirrahim. For our day 3 morning session, could I have the chairs here, please? Could I invite Professor Amir Ghafoor and Professor Habib Judun, please? Sir. So our first presenter is Dr. Shahid Habib. He's available online, and he'll be talking about NAFLD, and NASH, beyond diet and exercise.
Shahid, can you hear us?
Yes.
Okay, on you go then. Bismillah.
Okay, thank you, sir. Good morning. Assalamu alaikum. First of all, I want to thank you for inviting me for this prestigious conference. And I'm honored to be a part of this conference. So I've been given the task of NAFLD and NASH beyond diet and exercise. So the key treatment of NASH is actually taken out of the discussion today. So the difficult task is the pharmacotherapy. So I have no financial conflicts of interest to declare. So I'm gonna start straight from pharmacologic treatment, current approach of a disease, which is a disease of lifestyle. And we are trying to treat with pharmacotherapy instead of making changes in the behavior. And what is the current status on the pharmacotherapy in the treatment of NASH? So as of today, there is no FDA, Food and Drug Administration approved pharmacotherapy for NASH or any other medication approved worldwide by any regulatory authorities to be used as part of first-line treatment. However, in addition to this treatment with the lifestyle intervention, we use some medication in conjunction with the lifestyle intervention in clinical practice. And some of the medication we use are metformin, pioglitazone, liraglutide, and vitamin E. And all these 4 drugs have been studied to some extent in a randomized controlled fashion to evaluate the effect on NASH and its progression. So this slide actually shows the pivot study, 96-week results of pioglitazone and vitamin E in patients with NASH. So in this trial, the participants were 247. And it did show improvement in histologic features of NASH overall. And when it was dissected, the response was dissected based on individual characteristics of steatosis, fibrosis, lobular inflammation, hepatocellular ballooning, and overall resolution of NASH. It did improve the resolution. It did show the benefit on the resolution of NASH. However, as you can see in the fibrosis section, the results still stays statistically insignificant. So there was no improvement in fibrosis. Subsequently, it was thought that maybe the dose was inadequate. And then another group of investigators studied pioglitazone in diabetic patients with the 18 months duration in the subjects of 101 patients. And the endpoint was set as more than 2-point reduction in NASH score without worsening of fibrosis, resolution of NASH, and more than 1-point improvement in fibrosis. There were 3 endpoints. So when we say that NASH improved, the histological improvement in steatosis, fibrosis, or steatosis, ballooning, and inflammation, it indeed did show that. So NASH improved significantly compared to the placebo. 51% of the patients with 45 milligram pioglitazone showed histologic improvement in NASH compared to the 19% in placebo. Whereas when it comes to the fibrosis improvement, it failed to show any significant decrease in the fibrosis from the baseline. Vitamin E, basically it helps in the prevent the beta oxidation and reduces the inflammatory process. And it has been studied in a dose of 800 international unit. And in the previous studies, in the PIVONS trial, as you see that the vitamin E is comparable with the results are very comparable with the pioglitazone 30 milligram once a day. However, the long-term use of the vitamin E is associated with some side effects, especially with the hemorrhagic stroke and increased prostate cancer risk. So the higher doses greater than 800 international units are generally not recommended. Whereas the pioglitazone has the concerns of equivocal bladder cancer risk, osteoporosis in women, and then the weight gain as a result of the fluid retention. The use of vitamin E in the diabetic patient is still debated, and there's no clear evidence whether it is safe to use or not. And this is a lean study, 48 weeks of liraglutide versus placebo in overweight patients with NASH. And this is a small study, phase 2. And so as you can see in this study, liraglutide 1.8 milligrams subcutaneous injection was used once daily dose. And there are, on the left-hand side, this graph shows this is the blue bar showed liraglutide and the orange red bar showed the placebo, represent placebo. As you can see that there's improvement in this. This is in percentage of the NASH resolution. So 39% versus 9%. So the mean change rate is like more than 5.5% decline in the weight compared to 0.7% decline. And also the mean change in ALT was like a 26.6 unit decrease in ALT unit compared to 10.2 units decrease with placebo. So yes, there is some benefit of that, but whether it lead to significant improvement, the standard endpoints of fibrosis improvement or not, it has yet to be determined. So this, I put together these numbers just for the sake of comparison compared with what we have shown in the previous slides. And as you can see that this say the orange bar here, this is yellow bar represents the placebo, and this is NASH resolution, and this orange bar, which shows the highest bar, it represents the standard NASH resolution effect with the lifestyle intervention. So when we compare with all the clinical trials which have evaluated the efficacy of the lifestyle intervention, we see that it varies from multiple trials from 65% to 95% resolution of NASH. So on an average in the meta-analysis, 75% resolution of NASH has been determined in patients who follow the lifestyle intervention plan compared to those who don't. And the people who don't, then the lifestyle intervention, the resolution is not more than like 20%. When it comes to the fibrosis, the lifestyle intervention revealed almost for more than 40 to between 40 and 50% resolution in fibrosis, as compared to no fibrosis improvement, people who don't follow the lifestyle intervention. So as you see there, and this fibrosis change is significant compared to the people who don't follow the lifestyle intervention. But when it becomes a standard of care, then you see the other drugs which are compared with as a standard of care, there is no significant difference. They are not better than the lifestyle intervention in terms of the fibrosis resolution. And the long-term effect of the lifestyle intervention or any medication as available today, there's no data to see that if there is any reduction, risk reduction in HCC or liver failure or any portal hypertension related complications. Weight loss surgery has been studied, and this large bariatric surgery trial compared with the obese control have shown significant reduction in HCC risk compared to those who have not had any weight loss as a result of bariatric surgery. Statins are very important key player in the management of NASH. The 3 biopsy studies, including 20, 107, and 356 patients in all the 3 studies, showed that statin treatment had a protective effect on steatosis. steatohepatitis, and the fibrosis. Data suggests that statin treatment in humans substantially improve or cure NAFLD-NASH, but above all, substantially reduce the CVD, morbidity, and mortality. Administration of potent statins appears safe and effective in saving lives in NAFLD-NASH patients. So in summary, what we have today, how we're going to treat the NASH patient above and beyond the diet and exercise. So basically, this is a case of a 45-year-old patient with type 2 diabetic with NASH and F3 fibrosis asked to discuss the therapeutic option. So what we are trying to do here, the approach and the game plan is basically we focus on the lifestyle intervention plus minus bariatric surgery if indicated. Then we're going to focus on the treatment of metabolic syndrome or other concurrent confounders, which is the diabetes, dyslipidemia, and hypertension and diabetes. And then we're going to focus on the NASH. If it's a biopsy-proven NASH, then we're going to start using vitamin E, 800 units, but no more than 800 units. And pioglitazone, again, the dose of 30 or 45 milligram, preferably 45 milligram. And liraglutide, which is not recommended, but if you're dealing with a diabetic patient, then certainly you have a liberty, a leverage to choose this option. And what is the factors to reduce long-term concerns and the HCC risk? So statins and the metformin are the good choice. In addition to that, even though the metformin does not have any effect on the improvement in histology of NASH, but it does improve the overall survival. So the longevity of the life and the quality control depends, is achieved with metformin use in diabetic patients. So the potential target for pharmacotherapy. What is the future of the pharmacotherapy in NASH patients? At this moment, there's a race going on across the world. More than 95, almost 100 companies are working on this disease to find out. And more than 90 plus 90, almost 100 products are being investigated or have been investigated, and they are out of the race. So what is the current standard to evaluate the endpoints? So there are two endpoints: NASH resolution, the resolution of steatohepatitis on overall histopathologic readings, and no worsening of liver failure as a liver fibrosis, one composite endpoint. The second composite endpoint is the fibrosis improvement, which is improvement in equal or more than one fibrosis stage and no worsening of steatohepatitis. So you can assess each drug in both ways, and then separately depending upon the individual component. So this slide shows actually the number of trials going on or has been performed already. The red spot actually shows that these trials have been out of the race and they have failed. They did not show any statistical value or benefit in the regression of NASH or fibrosis. So you can see that the red spots are multiple and they're scattered all over the place in this area. And the green spots, basically the trials are going on. Some of these trials are phase 1, phase 2, or phase 3 studies. So before we move on to the future therapy, I would like to spend a couple of minutes to explain the pathogenesis of the NASH so that you can understand where these drugs are working and how they're going to work that. So just briefly, we eat food, including carbohydrates and fat, and it leads to stimulate kind of a microbiota, and it causes stimulation of the GLP glucagon-like peptide or glucose insulinotropic polypeptide hormone, and that secretly causes insulin secretion. And then food directly acts on the bile salts, and the microbiota also works on the bile salt. Bile salt also stimulates the insulin secretion and affects the FXR. The insulin, in turn, there are two main pathogenic signaling pathways inside the cell. And as you know, that there are 3 tissues in the body which are insulin sensitive: liver, muscles, and adipose tissue. So all these mechanisms happen. The degree of insulin sensitivity varies from tissue to tissue between liver, muscles, and adipose tissue. And the inside signaling mechanism also varies between among the three tissues. So major key signaling pathways are MAPK and PIK3. PIK phosphatidyl inositol kinase 3, and that lead to the PPAR, like peroxisome proliferator activated receptor, and then intracellular mechanism. And PPAR is a nuclear receptor, and that lead to the stimulation of the further enzyme mechanism inside the nucleus, leading to the transcription of the DNA and further production of the protein, hormones, and other ingredients that are required for the cellular growth, differentiation, as you can see here, and regeneration, metabolism of the nutrients, immune functions, and inflammation. So these are the three main cellular functions to control cell growth, inflammation, and metabolism of the nutrients. And this slide again shows the details of the very in detail, the further mechanism. So this is the PIK3 and this is the MAPK. And here, so it leads to the GLUT4, which is a receptor for the glucose transport, which is kind of, it should be here. And that lead to the transport of the glucose here, and then lead to all the, through all the intranuclear signaling pathways leading to the transcription, RNA splicing, protein synthesis, lipid synthesis. So all these diversity of the functions. So what we learned from this slide in a nutshell, we learned that insulin hormone control everything. That's the bottom line. The bottom line is that insulin hormone and the bile salts control everything, meaning that it regulates your cellular functions of cell growth, tumorigenesis, inflammation, and control the metabolism of the carbohydrate, proteins, and fat. So that's where the key mechanism is. So once we improve the insulin sensitivity, it improves subsequently everything. So here is the thing. So normally the process of NAFLD and NASH, it starts from the accumulation of the fat. So now it's a debate here, whether the fat comes first or insulin resistance comes first. We don't know. This debate continues. But however, as of today, our understanding is insulin resistance comes first, followed by the steatosis, and then insulin resistance leads to steatosis. Steatosis leads to the beta cell oxidation defects in the mitochondrial functions of the cellular functions, and that lead to the inflammation, and then subsequently stellate cell stimulation leading to fibrosis and cirrhosis and fibrinogenesis. So based on that, there are several products are being investigated, under investigation. So the insulin sensitivity, improvement in the insulin function is the key target as of today. A lot of companies, they are focused on that. And then the less focus is on the anti-fibrotic mechanism or anti-inflammatory mechanism, because they are in the far in the line. But the key product in the market as of today is the focus on the improving the insulin sensitivity. In the next few slides, I'm going to discuss with that. So PPAR gamma is as I say, is a nuclear receptor protein that functions as a transcription factor regulating the expressions of cellular differentiation development. So it's a nuclear receptor, just like an FXR farnesyde X receptor. So there are three kinds of PPAR receptors. One is the alpha, beta, delta, or gamma. So when you stimulate all three receptors combined, it improves the insulin sensitivity significantly as compared to the stimulation of only PPAR gamma, which is kind of the focus for the pioglitazone. So the new approach is to stimulate all three of them. And the drug which works with this, with the two drugs which working for the pan stimulation of the PPAR is the elafibranor and seroglitazar. Seroglitazar is approved in India for the treatment of diabetes mellitus, and that works the same way. And it has been shown in the animal model that it works very well for the NASH. However, final results, phase 2, phase 3 are yet to be determined. Incretins, which is the hormone that regulate the insulin secretions. So in response to the glucose and other nutrients, the incretins are secreted by the L cells of the duodenum, and they go into the portal circulation and causes through the endothelial action. So it leads to further release of the secondary signaling compounds lead to the stimulation of the beta cells of the pancreas, causing this release of the insulin, and that subsequently increase that. So what GLP is regulated by the DPP, this is dipeptidyl enzyme that inhibits the incretins, and the action of incretin lasts for only for few very short time. So the stigleptin, leptin, they are actually inhibitor of this enzyme, so or indirectly they increases the action of the gliptin, GLP-1 and these drugs. And subsequently, they release the increase the stimulate the insulin secretion and inhibit glucagon secretion, and finally leading to the lowering the blood glucose, at the same time increasing the sensitivity of the insulin. In light of the time, I'm going to be moving forward. Obeticholic acid FXR, kind of a, as we mentioned, a nuclear receptor. This has a multiple effect. The silonsertib, which is a apoptosis signal regulating kinase enzyme, which causes a apoptosis and oxidative stress. Oxidative stress is the key stressor here, which lead to this hormone accumulation and then lead to cell death. So if we block these enzymes, it will block the cell death and inflammatory process. And similarly, there's Viroc is another compound which is purely antifibrotic, which causes the block the process between the macrophages and the stellate cell pathways. So what we have as of today, so there's only one drug which has been passed the phase 3 trials, which is obeticholic acid, is called Regenerate trial. The other 3 compounds like silonsertib, sonicriviroc, and elafibranor, they are still in the phase 3 clinical trials. The results are not yet published. In the phase 2 trials, they have shown some improvement with the NASH resolution, but no improvement in the fibrosis. I'm running late. I hope it's fine. I'm just need 1 to 2 more minutes. This is the Regenerate trials. And so this is a 2,400 participant phase 3 study. This is evaluating the obeticholic acid. And in summary, there's only like a little more than 20% of the patient has resolution of NASH, the fibrosis improvement and NASH resolution, So there's kind of a reversal of that. So it's NASH resolution without fibrosis, and there's a no fibrosis change. So this phase 3 study actually did not show any significant improvement in fibrosis. However, it did show that almost like 1/4 of the patient has resolution in NASH. This is the stage. This slide summarizes the results of all the other ongoing trials with the phase 2 results. This is kind of a busy slides. I will leave it up to the audience to have later on to review that. So in conclusion, thus far, lifestyle intervention is the most effective therapeutic approach with higher rates of NASH resolution and improvement in fibrosis. Long-term benefit of the lifestyle intervention on mortality and HCC risk reduction remains unknown. Sustainability of lifestyle intervention is a challenge, thus warranting development of a magical drug. Future research is directed towards finding an agent that can improve liver histology, have favorable cardiovascular and metabolic effects, demonstrate long-term safety, mortality risk reduction, and HCC risk reduction. As the pathogenesis of NASH has been shown to be complex and multifactorial, future treatment of NASH will also be multifaceted, targeting multiple pathways. Myriad of treatments in the phase 2 clinical trial pipeline, including agents directed at addressing steatosis, lipogenesis, immune modulation, oxidative stress, apoptosis, and fibrosis. The drugs investigated to date have been shown to yield far less than 50% improvement in histological outcome, as you have seen in that slide. So none of the drug actually has more than 40% of the histological improvement in NASH without worsening of fibrosis. And none of the drug actually has shown any improvement in fibrosis except the antifibrotic drug. The drug Sinicry, Viroc, which is the only antifibrotic drug, and that's the only drug that has shown some improvement in fibrosis, but that drug did not show improvement in the histology of NASH as expected. And lastly, the NASH treatment probably will require using multiple drugs to achieve maximum therapeutic effect at the different stages of the disease. For example, if the patient with NASH and stage 1 to fibrosis comes, probably the best combination would be to target steatosis and oxidative stress and or immune modulator. And if the patient is coming with advanced degree of fibrosis, a combination of antifibrotic agents and with immune modulators are the drug of choice in addition to the lifestyle intervention. So I conclude here. Thank you very much for this great opportunity.
Thank you, Dr. Shahid, for a wonderful talk. So our next speaker is Brigadier Muwaddiz Rana. So he'll be talking about biopsychosocial issues in gastroenterology, physicians and psychiatrists' perspective. Are we audible, sir?
Yes, you're audible. Thank you very much. I'm just wondering if I'll get the chance to share screens.
We can hear you, sir.
Hello, but I would need to share the screen. So I was wondering if I get that.
You can
option.
share, sir. You can share, sir. Click on share screen button, sir.
बेटा शेयर का इनको दे देना सर नीचे शेयर का वो ऑप्शन है यू जस्ट क्लिक ऑन दैट आपके स्क्रीन के नीचे शेयर होगा सर
जी मैं देखता हूँ।
सर बॉटम में देखें आपके एक ग्रीन बटन आ रहा होगा उसके ऊपर शेयर स्क्रीन वहां पे क्लिक करें
पहले अपनी
Okay. Have we got the screen with the audience? Please?
yes sir we can see
Okay, honorable chairpersons, ladies and gentlemen in the audience. It's a Sunday morning, and I know it's a very, very tough ask to expect people attending a conference to wake up in the morning for a talk, that too by a psychiatrist in a gastroenterology conference. So having that challenge, let me immediately start by trying to highlight this particular aspect, which I, as a psychiatrist, find very commonly at play with the patients that I see, largely because of the fact that there are several referrals that I get from my colleagues from gastroenterology, where when I look at the prescriptions and the descriptions and the investigations, most of these patients initially were thought to be suffering from gastrointestinal diseases. And yet, when they're referred to me and I start to treat their anxiety and depression and whatever else they have, I still find that some of their gastroenterological issues continue to bother them and worry them. And that is that provides an impetus to this talk, that is it so that psychiatrists alone and gastroenterologists alone may not really be looking at the entire picture of what all goes wrong in the life of a patient. And therefore, I'll try and highlight some of the themes that might interest the audience here of these overlaps between psychiatry, between psychosocial factors and the biological factors. And the excellent presentation that I've had the pleasure of listening to this morning gave me strength, because we were constantly talking about medication, but we were also referring to the effectiveness of lifestyle changes, sociological factors playing role in taking care of patients with NASH. So I'd continue in the same vein and try to highlight to you how we can actually understand the role of psychosocial factors in gastroenterology in more detail. This, of course, is a gentleman that many of us are familiar with, who came up with the biopsychosocial model. He had started to write about it in 1971 onwards, but found a lot of resistance on the fact that the entire training of doctors is essentially biomedical in nature. And when we think in terms of biology, we think in terms of medication and surgical interventions. That's how we are trained. So psychosocial factors, by and large, and I speak for Pakistan particularly, for long has been an ignored area. This is an area we think, okay, let's just tuck it away from our sight and let the psychiatrist deal with it, or the psychologists come and play their role in it. For a hardcore gastroenterologist to take interest in the psychosocial aspects of his patients is something that seems to be a forbidden area, an area that most gastroenterologists would not bother or would not have the requisite time and energy that is required to probe into the realm of psychosocial factors. Yet George Engel thought, and I'm sure there are several papers that since then have come out to show that this is not really a long shot. There are a load of psychosocial factors that play a role in changing the picture of gastrointestinal issues. Now, when we look at it from that aspect, psychosocial factors seem to not only be of etiological significance in patients with gastrointestinal disorders, but also influences the way the symptoms will present, how the disease will progress, what will be the interventions required in a patient, and what will be the eventual outcome, which sometimes, if psychosocial factors are not addressed adequately, becomes very, very frustrating, because you're doing your best to look after this patient. You've undertaken every investigation under the sun, and yet the patient continues to suffer. And that is when I think it is important to raise the red flag and say, okay, we need to look at probably a psychosocial issue operating. Now, this picture is very, very familiar to all of us. And here we see an interesting state of the gastrointestinal system in this gentleman who went through a spiritual experience and saw the light, as he called it. And the awakening that he had was after 40 days or so, as it is described, sitting under a banyan tree, eating nothing at all. So he had somehow discovered that gastrointestinal system and the way you get into a state of hunger starts to bring in a lot of spiritual dimensions in a person's reflective state. And even today, as you and I are awaiting Ramzan, we know that during the Ramzan, one of the things that we are constantly preoccupied with is our gastrointestinal system. Sehri mein kya khayenge, iftar mein kya khayenge, iftar mein kya hoga, sehri mein kya hoga. We'll obsess on this for a month or so, and many people would have various kinds of thoughts. But essentially, traditionally, what I'm trying to say here is that there is a link between the mind and what happens to the gastrointestinal system. And this picture actually is a testimony that this is not a new thought, that this is something that people have thought about many, many centuries ago. As you know, it lived around 350 or BC. So clearly we are talking about a very long time since this particular aspect of link between gut and spirituality, the importance of fasting and hunger linked with spiritual experiences. And we know in the East, in particular in the subcontinent of India, the tradition of control of nafs. Now, control of nafs nearly always is about gastrointestinal exercises. Gastrointestinal exercises here means to go on, you not eat for days at end. When you're doing a chilla, you're controlling your nafs. There are all sorts of interventions that are essentially focused and primarily focused on one's gastrointestinal system. So highlighting the significance and importance of spirituality and GI tract. Now, this is going beyond the biopsychosocial model of Engel, that there is not only just psychosocial, but a spiritual dimension attached to gastrointestinal tract as well. If you go further, you would hear this connection in literature as well. There are lots of words that are used, phrases, poetic expressions, novels, in which gut is somehow is linked with feelings and emotions and desires. We have certain muhavras, for example, in Urdu, जिनका ताल्लुक, भाई तुम्हें तो बहुत मरोड़ उठ रहे हैं, तुम्हें इस बात की पेट में क्या तकलीफ हो रही है, पेट में क्या तकलीफ हो रही है, बात की. So and then of course we have relationships in which the depth of our relationship with somebody, oh wo to mera jigar hai. So all these literary references also suggest that traditionally human beings have somehow felt a connection between the human mind, human feelings, human emotions, their spirituality, and the gastrointestinal system. Traditionally, gut and mind have been also a subject of concern in Ayurvedic medicine, in what we in our part of the world call Unani medicine or Hikmat, where constipation is supposed to be the phenomenon that is at the center of every possible disease. Kabz ho gayi hai, badi ho gaya hai. All these are very, very gastrointestinal themes that are pursued traditionally. Laxatives and emetics are used primarily to heal people. And I tell you that these are standard treatments that were practiced in many asylums for psychiatric patients. They were given massive doses of laxatives and emetics to get them away or out of their psychotic state. So it was not just the Ayurvedic medicine, but it was also some of the asylums where this particular thought of the link between gut and mind was practiced. Then, of course, our psychiatric situations and circumstances where we've had input from our gastroenterology colleagues, and you can see in the slide how actually therapeutic methods linked entirely to at the diet of people were influencing conditions like melancholia and schizophrenia, hardcore psychiatric disorders where there were these, of course, most of these hypotheses were thrown out of the window subsequently, but well, around that first half of the last century, all this was going on, where you were looking at gluten-free diets and casein-free diets as interventions for conditions like schizophrenia and psychosis and very severe psychotic depression. Then, of course, is a far more recent perspective, and that is linking up microbiomes in the gut and developing what they call a microbiome gut-brain axis, highlighting that actually people can experience anxiety and depression on account of no other risk factors in their psychological and social realms, and not even in terms of any brain changes or any psychological trauma, but as a consequence of what is termed as dysbiosis and inflammation of the gut. And there's more and more talk of probiotics used essentially. And if you go to a conference now of psychiatry, you would find a couple of papers essentially looking at the role of probiotics as anti-anxiety and antidepressant agents. Then, of course, is this new dimension of medication that is coming out, and there's more research focusing on creating a whole group of psychotropics called the psychobiotics. So I'm sure these are not unfamiliar terms to gastroenterologists, but you can see how much you are influencing the realm of psychiatry and the therapeutics of gastroenterology is influencing the psychiatric perspective of medicine. Now, this actually is something that I would expect everybody to focus on, because this is very recent. This is an area where the prefrontal cortex, which is the seat which actually juxtaposes human beings with their psychosocial world, where all the cognition takes place, where all the thinking takes place. And this is where you interpret the social cues that are coming your way. And it is this realm of the prefrontal cortex which then influences the limbic system. And these two areas are now exceedingly seen as the highest or the higher centers of the all familiar hypothalamic pituitary adrenal axis that we have been traditionally taught about. So everything started with hypothalamus and finished with adrenal glands. Not anymore. There's more and more influence of the emotions and feelings, memories that people have, psychological traumas, early childhood bringing, lifestyle practiced by parents, influencing the children through memories, through the limbic system and through the prefrontal cortex, influencing the entire realm of hypothalamic pituitary adrenal axis. But that is not where it is ending. It's now going on to include gut as an integral part of this axis. So the word has moved and gradually moving into understanding the way a cortisol releasing factor and vagus nerve influencing what? Just not the epithelium of the gastrointestinal system, but also the smooth muscles of the gastrointestinal system through the influences of vagus nerve and the cortisol releasing factor and several other neurotransmitters that you know are produced by the gastrointestinal system in itself, and they are neurotransmitters. So here is this realm that probably future conferences of psychiatry and gastroenterology need to probably focus a little more on. All in all, what I can now say is very safely that gut is the new playground for biopsychosocial model proposed by Engel. That autonomic nervous system and neurotransmitters and microbiomes are words that we need to be more familiar with. We need to talk to each other more, psychiatrists and gastroenterologists, because we are going to find tremendous overlaps. And just as a testimony to what I'm trying to say is that there's now clear evidence that these bacilli and these organisms that you entirely deal with and we are oblivious about are producing neurotransmitters. They're actually secreting, producing neurotransmitters, which are getting absorbed into the circulation of a human being. So noradrenaline is not anymore the realm of adrenal gland. It is now as much a product of the microbiome of the gastrointestinal system. And serotonin, the happy chemical of human brain, is also being produced by these microbiomes inside the gut of an individual. So may I conclude by saying that this individual that we have been always telling people कि कैसी बेवकूफों वाली बात करते हो, गैस कैसे पेट से दिमाग को चढ़ सकती है. Here, let us stop and think and reflect that was he not always right? There was a connection between the gut and the brain. Thank you very much.
Thank you, Dr. Muwaddat Rana, sir, for an interesting talk. So next speaker is Dr. Lubna Kamani. She'll be speaking on ergonomic injuries in endoscopists.
Assalamu alaikum everyone and good morning. I would like to thank organizers for giving me this opportunity. The title of my talk is Ergonomics of Endoscopy. This is the first time that we are presenting this topic in any of the Pakistani GI Society. This is somewhat new to the GI world, but actually in the literature, it's not new, but the concept of ergonomic is still evolving. So what do you mean by ergonomics? Yesterday, many trainees and the students asked me, what is ergonomics? They don't know what is ergonomics basically. So it's a Greek word which means ergon and nomos, arriving from ergon and nomos means ergon means work and nomos means natural law. Can you switch off this light because it's directly on my face and I can't see. Can you switch off this light, please? Thank you. So it's an applied science concerned with designing and arranging things people use so that the people and things interact most efficiently, safely, and effectively. It has given me various terminologies naming biotechnology, human engineering, and human factors. So if you see the literature, this ergonomics business dates back in 400 BC in ancient Greek civilization where the archaeologists have drawings and paintings of chairs with contoured backrest. And it resembles design still used today, basically. And if you see that Hippocrates, they documented some of the earliest thoughts regarding this workflow pattern to improve efficiency and efficacy. And specifically, they designed and wrote how a surgeon's workplace should be designed and how the tools should be designed and should be arranged. Followed by Italian, Ramazzani wrote a medical journal regarding complaints and diseases of the workers. And what they have noticed that there were multiple injuries such as weaver's bottom, writer's cramp, telegrapher's wrist, and housemaid's knee, outlining how these injuries relate to working environment and occupation of his patients. So this initial evidence suggests that this concept of ergonomics dates back many, many years ago, basically. So what type of injuries? We are all involved in endoscopy day in and day out, and sometimes we boast that we do 30 procedures per day, 20 procedures per day, but it can be disastrous to your health, basically. So the common injuries which the colonoscopist or endoscopist gets is recurrent sinusitis, repeated controls of diets, and injury to the metacarpopharyngeal joint because of forceful pinch, grip, torquing, tightening, twisting, and especially in difficult patients and difficult procedures. Carpal tunnel syndrome, lateral epicondylitis, and other common regions of pain in the back, neck, shoulders, hands, and fingers. So these are the various injuries that an endoscopist faces during lifetime. So why we are talking of this ergonomic injury, is it important? Who cares? Or do we need to care at this point in time? So according to surveys, 30 to 80% of the endoscopists report some work-related injury, and 1 in 5 had to take time off from work because of this injury. Over 50% modified practice, 65% sought treatment. But we don't have any head-to-head randomized group trials, and these initial data is basically dependent on the surveys and reports. So these are the few studies, and recently a study published last year in endoscopy. So the prevalence of musculoskeletal symptoms in gastroenterologists ranges from 37 to 89%. Skeletal muscle complaints are more common in gastroenterologists than internal medicine consultants. Gastroenterologists spend about 45% of their time performing endoscopic procedure and on an average 12 endoscopy and 22 colonoscopies per week. This is an American data basically. Probably we are doing more than that. Musculoskeletal injuries risk linked to a high volume endoscopy practice, more than 20 cases per week or more than 16 hours per week. Total number of years are directly proportional to the cumulative injuries that we get. So when we talk about ergonomic injuries, so should we stop doing endoscopy? No, I'm not saying that. But your posture, your position should be correct. So the best posture is the neutral posture. What do you mean by neutral posture? Simply refers to the resting position of each joint so that there is least tension on your ligaments, muscles, bones, nerves, tendons, and working in awkward positions increases the exertion and force and thus apply tension to the muscles leading to injury. During each procedure, if I say, one fiber of your muscle is getting lost. So one or two procedure does not matter, but over the years, we are not here for 1 to 2 years. We practice gastroenterology for 30 years, 40 years. So the injury is negligible on one day or 1 week, but if you arrange it in a cumulative manner, it's massive. So what are the endoscopic ergonomic risk factors? Forceful exertions, awkward postures, people, residents, doctors posting pictures on Facebook, media, and when I see them, their posture is totally incorrect. They are leaning on one side, they are bending, they are doing extensions. So you need to keep your posture straight. This is very important in long term, in order to avoid long-term injury. Sustained positions, repetitive prolonged activity. Our same procedure we need to carry out again and again, endoscopy and colonoscopy. So it's a repeated movement of the same group of muscles and tendons. Vibration, using of heavy equipment, like in pandemic, we were wearing all sorts of PEE, the shields, the goggles. So this gives an extra burden on the body. And of course, when we do ERCP, we have to wear lead apron. That is again a very heavy additional equipment. And again, environmental conditions like infectious agents, ionizing radiation, exposed wires. So these all accumulate. When we say that there are two things or three things, and it's not two or three, it accumulates and become 10 or 12 times more dangerous. So what should we do? Should we train a future generation of gastroenterologists like an athlete? So these are the articles that are coming up in the literature. Should we give them muscle training for each group of muscles that is involved in endoscopy? Because the young gastroenterologist who enters is wanted to complete the procedure, the eagerness of them that they want to complete the procedure. And because the consultant or the supervisor also have a busy day schedule, they are just in a hurry to complete the procedure to get the therapeutics done, least concentrating on the position of the trainee, that how he's doing basically. So this is very important. So now this is the need of the now. We always thought about the safety of the patient. Now it's time to change. With the patient, we have to include the safety of the endoscopist as well. We need to think of ourselves. If you are 100% healthy and hearty, then only you can give 100% of your output to your patient, to the society. The concerted effort from endoscopy societies is needed to standardize ergonomics training and to ensure that working environments are ergonomically sound. So if you see the scopes of which are available in the world, it's just one size. So one size does not fit all. They does not come in various sizes basically. Asian smaller build, glove size less than 6.5. Unfortunately, women disadvantaged need foot paddle. Female gender in some studies is independently associated with musculoskeletal injury. But this will not, demoralize us being female and not doing endoscopy for sure. Women's grip strength to be 59% of the men's and finger touch pinch strength force to be 71 to 73% of the men. Suboptimal grip, which means you need to add more force, 2 times more force than men required, which is a biomechanical disadvantage leading to injury. So what to do? Because if someone has a smaller hand size, he or she is more prone to ergonomic injury. Or if the Asians, especially if you go in Far East, they are smaller built, so they are more prone. So what to do if you sustain injury? Modify your practice, change your technique. This is important. You can do endoscopy by sitting. Reduce your workload, spread out your workload basically, and assess your ergonomics in the room. There are various studies which show that 55% of the injured endoscopists applied practice modification in response to injuries. Specific treatment, including from simple conservative treatment to steroid injection, physiotherapy, rest, and in some instances, surgery as well. Work-related injury can be devastating to the career of an endoscopist. Endoscopic related musculoskeletal injury result in lost and restricted working days. So we have a domino effect. For those who don't know what is domino, it is a event which then lead to sets of a series of events. So if you have a injury which will result in loss of productivity, change in outside physical activity, your social circle, your family will be suffering. This can lead to career shortening. Few of the senior endoscopists, they don't do ERCPs or complex procedure anymore. They refer to a junior colleagues basically, and they are more into, non-invasive or more into counseling or clinic-based practice these days. And then can lead to psychological effects. Disability insurance, financial protection against potential injury. We don't have this sort of system in Pakistan. So we need to take care of ourselves, because if you are not healthy, your family, your work, your patients will suffer. So how to eliminate this? We start with the hierarchy of controls, which is elimination, prevention through design, and endoscopy. This is high time that the various companies who are designing these endoscope should make now tailor-made endoscopes for various people, because the world has different cultures, different their dynamics, and different their body posture position. So we need to have different endoscope that suits everybody's hand size and the surroundings. Then the endoscopy suite need to have some modification. We need to have adjustable monitors. We need to have adjustable beds, support stands, caps, right and left dial assist. Then we need to add in our training program ergonomic training, safety culture, ergonomic timeout. I'll talk about it in later slides. Endoscopy schedule and endoscopy maintenance, because if your endoscope is old, it's stiff, this will, you need to apply more force. So you need to have a regular maintenance check. And of course, the micro break and stretches is very important. It has been said that after every 30 minutes or 40 minutes, you need to have 1 to 2 or 3 minutes of break in which you can do stretch exercises. So what about the work environment? Monitor should be directly in front of the endoscopist to minimize neck rotation. The height should just below the eye level to prevent neck extension. Viewing angle 15 to 25 degrees below the horizon. Viewing distance 15 to 182% was 52 to 182 centimeter. Bed level adjusted to elbow height 10 centimeter below elbow to prevent lower back flexion. So you don't need to bend while doing endoscopy. You need to have a straight posture. So what else we can do to avoid these injuries? We can have cushion gel, anti-fatigue mats basically, footstool, compression stockings, cushioned insoles. Your shoes matter, so invest in your shoes basically. Foot pedal to take pictures, and instead of one-piece lead apron, wear a two-piece lead apron that distributes the weight on the body. Endoscope stands, angulation dial adapters, caps, endocuff towel grips, and self-propelling scopes, which will be the future direction of endoscopy. So the neutral position is that a comfortable stand, standing on both feet, equal weight distribution, and natural curves in back and neck should be maintained. So what is ergonomic timeout? It's a checklist basically. Monitor placed directly in front of the eyes, 15 to 25 degrees below the eye level. Raised procedure bed bringing endoscope to 10 centimeter below the elbow height. Floor cushion in place. Floor pedal in front of body. Back, upper and lower extremities in neutral position. Two-piece lead apron preferred over one piece. Cords and wires contained on floor, and implementation of micro breaks and stretching basically. This is very important. So when I say knob extenders, these are the knob extenders you can put for, especially for those in which the hand size is smaller. Generally, these are not available here, but these are available in more developed countries. And the cushion floor mats, which give you, the support for the back and on the leg. But if it's not available, you can wear cushion shoes, basically. These are available and you can invest in that. So these are some stretch exercises that you can do. It's a simple, you can take 1 to 2 minutes, 3 minutes break. You can do extension, abduction, flexion of the wrist, fingers. You can take rubber band, which gives you a slight resistance exercise. So after every 30 minutes or 40 minutes, you take 2 to 3 minutes break and do these exercises. This will go a long way. So it's time to redesign our scope. We are having these scopes for last many, many years. So these are some few scopes which are, in the trial basis. First one is the self-propelling scope with the help of balloon. These are robots and magnetic with a robotic control, and these are the future. This is again a pill basically, and the patient ingest, and then you can have images. This is another future design of endoscope without any wheels, because it has been seen that the wheels are problem because we need to do repeated movements with the wheels. So they have omitted, and in US they have done couple of endoscopies on this design scope. And you see that there aren't any wheels. It's basically the fat plate. So the joint movements are less, and there's less torsion and less stress on the finger movements. So this was my article, which I published last week in Clinical Endoscopy. And last year in PSG Conference, we gave this survey to all the endoscopists, and then we compared with the non-endoscopists. We had 61 endoscopists on board and 31 general physicians who were not involved in any procedures. So these are the parameters that we saw on basically the hand size, the number of procedures they are performing, whether they are taking regular breaks or not, what type of procedure they are involved, and how many years into practice. And this is the pattern that we had, that basically in endoscopies, there was more back pain, leg pain, because they have to stand for prolonged hours. And there is more hand pain because of the movements that they are doing, as compared to non-endoscopists in which there were more shoulder pain and thumb pain. Probably they were continuously writing, so because of that. So the results of this study was the ergonomic injury were much higher in endoscopists, 95% as compared to non-endoscopists, which has a significant p-value. And 68, 70%, two-thirds of the endoscopists were obese or overweight. The sites of musculoskeletal pain were different in both groups. Mainly in endoscopists, there were back, leg, and hand, and which was expected. 44.8%, more than almost half of the endoscopists with musculoskeletal pain did not take any break during procedures. Those who were taking regular breaks between the procedure had 0.61 times lesser risk of developing procedure-related injury. One interesting study, which was in contrast to previous studies, that in our study, endoscopists performing more than 20 procedures I have written opposite. The people who were performing more than 20 procedures per week has less injury as compared to those who were performing less. So we said, how is it possible that people performing less injury, less procedures, having more musculoskeletal pain? So when we did sub-analysis, we saw that they had musculoskeletal injury. That's why they are performing less, and they have modified their practice basically over the years. So what are the research? This is a very important research avenue. And what are the research questions? What is the impact of pro-ergonomic interventions on injury and disability? How cost-effective are ergonomic intervention? Should we invest in ergonomic related things? Should we invest in these things in order to prevent injury and to modify? What is the optimal work rest cycle to optimize productivity while reducing injury? How much work should we do? How much break should we do? How much space out we need to do? We don't know the answer. Are there exercises, specific exercises, muscle training, weightlifting we need to do, resistant exercises in order to prevent injury? So these are the research questions basically. So what are the take home points? Advocate for better scopes. This is the time that we need to change the normal, these two dial scope. Optimize room design, that we can all do. And we need to involve their specific designers who design these ergonomics or theaters. We need to involve them. Optimize positioning and body mechanics. Treat yourself as an endo athlete. prepare and empower your team. These are real pictures of senior endoscopists who've been doing endoscopy for 30 to 40 years. And look at the hands, look at the back. This is the gift you get after 40 years of practice. So my advice is act now in order to prevent these injury and before it gets irreparable or irreversible and before it's too late. Thank you.
Thank you, ma'am, for some very useful tips on how to avoid ergonomic injuries while we are scoping the patients. So our next speaker is Dr. Rustam Khan, who will be talking about nutrition, principles and applications for GI patients. Can you hear us, sir?
Yes, I have sent my recorded presentation. Yes.
Okay.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. First of all, I would like to thank organizing committee to give me opportunity for this presentation today. Today, I will discuss about nutrition principle and application for GI patient. I have nothing to disclose. There is no financial interest adherent to my presentation today. I will cover in the next 15 minutes about what are the malnutrition and its consequences, how nutrition principles are applied in GI diseases. What is malnutrition? Malnutrition is sustained imbalance between nutritional availability and requirement. That is demand and supply mismatch. Malnutrition is also called protein energy malnutrition or protein calorie malnutrition. On the other hand, state of excessive availability of calories, for example, obesity is also a form of malnutrition, but it is dealt with separately. In common language, malnutrition is applied for undernutrition only. How malnutrition is prevalent? In American hospital, about 30 to 50% admitted patients are malnourished, and in a European hospital, 21 to 37% patients are malnourished. And patient with malnutrition has adverse outcome of the disease, more complication during admission, prolonged hospital stay and cost of treatment, and increased readmission rate after discharge. We did survey in our patient with cirrhosis regarding malnutrition, and we found that in decompensated cirrhosis, about 98% of them are mild, moderate to severely malnourished. And majority of them has poor perception of the knowledge of the diet. And when we break up these perception of diet according to their educational level, it was found that both educated and non-educated patients has different myths regarding the diet in liver diseases. This is another study from Korea. Here you can see that GI is one of the subspecialty where significantly more patients with malnutrition are admitted, and other specialty includes pulmonology, renal disease, cancer patients, psychological disease. How nutritional assessment and screening principles are applied to GI patient? Nutritional risk screening is to identify the patient most likely benefit from nutritional therapy. And every patient admitted to hospital is screened for nutritional risk within 24 hours of admission, and those with high risk are referred for complete assessment. There are several tools used for that purpose, and one of them is NRS 2002. And in this tool, nursing staff on first encounter to the patient check their weight and height and calculate their BMI. If it is less than 20.5, and if on history, patient say anything about weight loss during last 3 months, if patient not even eating well in last 1 week, if patient is sick looking, if answer to any of these questions is yes, then this patient is referred for complete nutritional assessment. And in a nutritional assessment, there is a history is taken regarding diet and any symptom, GI symptom, and pertinent clinical examination is done, and some anthropometric measurements are taken. For example, height and weight and BMI is calculated, triceps skin fold thickness is tested, mid-arm circumference can be tested, and few investigations can be checked. For example, CBC, lymphocytic count, then albumin, pre-albumin, and transferrin, etc. And based upon the result of nutritional assessment, a tailor-made nutritional care plan is developed for nutritional intervention. When we check biochemical measurement for nutritional purpose, plasma protein, albumin, pre-albumin, and transferrin can be checked. Albumin is poor indicator for protein malnutrition because its half-life is 21 days. It is affected by infection, medications, and liver diseases, where not only the malnutrition, but synthetic function of the liver is also accounting for low albumin level. Pre-albumin is better marker of nutritional status because its half-life is 2 days. Coming to muscle function, hand grip strength measures forearm lean muscle mass. It is not reliable for acutely ill patient or the patient with hand or arm motor abnormality. Subjective global assessment. This is a bedside tool where that can incorporate weight changes, dietary intake, functional capacity, and preliminary medical diagnosis. It is validated for oncology population also. And on the basis of this tool, you can divide your patient into well-nourished, mild to moderate malnourished, and severely malnourished. After assessment comes the calorie assessment. There are mathematical equations used for that purpose. For example, Harris-Benedict equation. These are separate equations for male and female. And there is a Mifflin equation, and which is slightly better than Harris-Benedict equation. But if you don't rely upon these cumbersome calculation, you can determine 24-hour calorie requirement by multiplying 25 with the weight of the patient in kilogram, and then this way you can get 24-hour calorie requirement. In few cases, indirect calorimetry is also used to assess the calorie requirements. Nutrients required for the patients are macronutrients. Carbohydrate, fats, and proteins are macronutrients. About 60 to 70% of non-nitrogenous calories should be supplied by carbohydrate. 20 to 30% should be supplied by fats. And protein is a nitrogenous source of energy. And it is also required for different metabolic processes inside the body, and 24-hour requirement is about 0.8 to 1 gram per kilogram per day. Amongst the macro minerals, calcium, phosphate, and magnesium is required for the patient with their balanced diet and nutrition. Micronutrients required for the patients are chromium, copper, iodine, iron, magnesium, selenium, and zinc. And there are water-soluble vitamin, including vitamin C and fat and vitamin B complex series. And there are fat-soluble vitamin, which is also required for the body for their growth and to supply their nutritional requirement. And these micronutrients are required for so many intermediary metabolism going on inside the body. Coming to special situations and nutritional intervention. For example, short bowel syndrome. It is also called intestinal failure. There is loss of intestine that preclude adequate digestion and absorption. And Crohn's disease, intestinal trauma, and intestinal infarction are the most common causes. Nutritional management depends upon the location of the small bowel removed, segment left behind, and presence of colon. Intestinal rehabilitation is most successful if colon and ileocecal valve is preserved. Nutritional management in the patient when short bowel syndrome or proton pump inhibitors are used to reduce the gastric hypersecretion. Parenteral nutrition is used to meet nutritional need initially. Oral feeding is gradually started while volume of parenteral nutrition is reduced. Cholestyramine can be used for the bile salt induced diarrhea. Vitamin B12 is given monthly by parenteral route if terminal ileum is removed. Trial of small peptide, low fats, enteral formula for significant small bowel resection is used. And if remnant bowel is less than 80 centimeter, then this patient requires lifelong dependency on parenteral nutrition. Nutrition in pancreatitis. Nutritional support is imperative for severe and relapsing chronic pancreatitis. Early enteral nutrition reduces complication and mortality than nothing for oral regimen. Parenteral nutrition is associated with central line catheter sepsis and hyperglycemia. Intrajejunal feeding is safe and well tolerated, and standard fat-containing polymeric enteral formula can be used. In Crohn's disease, there is hypermetabolic state and patient is anorexic due to nausea and abdominal pain. Deficiency of magnesium, selenium, potassium, zincs are common due to diarrhea and fistula. Dietary therapy is important, but no specific diet is recommended. Enteral nutrition may be important for those who cannot eat, and enteral nutrition not superior to parenteral nutrition to induce remission. Parenteral nutrition is restricted for the patient failing conservative medical therapy in situations where enteral nutrition cannot be delivered. Nutrition in liver disease. Malnutrition is common in cirrhosis due to decreased dietary intake and hypoalbuminemia resulting in small bowel mucosal edema and poor absorption. Decreased bile salt production result in intolerance to fat and fat-soluble vitamin absorption. Depletion of muscle mass and glycogen storage lead to dependency on protein stored for energy. Limiting protein intake is not recommended in cirrhosis, and dietary counseling and nutritional supplement is beneficial for patients with cirrhosis and patient undergoing liver transplantation. Nutrition in diverticular diseases. Data suggests high fiber diet will reduce occurrence of symptomatic disease. Fiber intake should be at least 25 grams per day, as insoluble fibers such as wheat, bran, and fiber-based cereals. Nutrition in dumping syndrome. This is common after partial gastrectomy and vagotomy. Hypertonic gastric secretion empty rapidly into small intestine, and consequently 25% of the plasma volume is diverted to the small intestine. Patient feel nausea, cramping, diaphoresis, and palpitation. And nutrition therapy for dumping syndrome is low osmolality solution by frequent ingestion of small meal containing fat, protein, and complex carbohydrate, and limiting simple sugar. Fluid intake is restricted and it should be separated from the solid food intake to avoid rapid gastric transit. Nutrition in celiac disease. In celiac disease, there is a mucosal injury and malabsorption caused by gluten-containing food like wheat, barley, rice, and oats. Patient present with diarrhea, cramping, marked weight loss, and often iron, folate, and fat-soluble vitamin deficiency. And treatment is gluten-free diet. Corn, rice, meat, vegetables are allowed, and most patients improve with dietary management if compliant. Nutrition in cancer patient. Protein calorie malnutrition is common in cancer patient, and cancer cachexia induced by tumor through multiple metabolic abnormality. Parenteral nutrition is beneficial for the patient with GI obstruction from primary or metastatic tumor. Enteral nutrition is beneficial for the patient with head and neck cancer to prevent weight loss and reduce hospitalization. Nutritional support in cancer patients should be restricted to those with a reasonable life expectancy. Nutrition in irritable bowel syndrome. In irritable bowel syndrome, high fiber diet is global benefit for number to treat analysis is about 11%. Fiber not helpful for the pain relief, but it is beneficial for constipation and firming of the loose stool. Gradual increase of supplemental fiber to 10 to 15 grams per day is important. And there is a group contained in the food called food map, which is fermentable oligo, monosaccharide, and polyols. And after determining these food group, these are eliminated and they are sequentially replaced after determining which patient is sensitive to which dietary component. In this way, you can make your dietary supplement to these patients to improve their symptom. Nutrition in colorectal cancer, high fiber diet, fish, garlic, exercise, Mediterranean diets are helpful and decrease the risk of colorectal cancer. And high intake of food and fruits are also beneficial, whereas obesity, cigarette smoking, red and processed meat, alcohol more than 30 grams per day increase the risk of colorectal cancer. So in conclusion, ladies and gentlemen, malnutrition is a common problem in hospitalized GI patients and it adversely affects the disease outcome. Initial nutritional risk screening and assessment is essential to avoid malnutrition in hospitalized patients. Disease-specific and tailor-made diet plan is important in certain conditions, and follow-up and monitoring and re-evaluation is essential while dealing the cases with malnutrition. These are my references, and thank you very much for your patient listening. We will come to question and answer later in the question and answer session. Thank you very much.
Thank you very much, sir. So our last speaker for the session is Dr. Nadeem Tehami. He'll be talking on optimal hepatobiliary pancreatic endoscopy post-pediatric surgery. Is he online? Okay.
Okay, that's fine.
Rahim, I'm grateful to Brigadier Masood and my dear friend Colonel Saad and all the members of organizing committee who have worked tirelessly and hard to get us today on this forum. I hope we can meet next year and have great fun like we had last year. Excellent meeting organized by Professor Amir Ghafoor. The topic assigned today to me is radiation-induced GI injury, which is actually a very important and emerging entity. So I hope you can see my slides well. I don't have any disclosure, and this is the hospital in Nottinghamshire where I work. I will briefly go through pathogenesis, and I will then concentrate on radiation enteritis, which is the most common effect of radiation on GI tract. I will introduce you to RAVE, which is radiation-associated vascular ectasia rather than chronic radiation proctitis, and some salient features of management and prevention of this condition. And before we go into the detail, I think it's important to understand the basics of radiation and radiotherapy. So when your body is exposed to radiation, whether that is due to therapy for a cancer or due to a disaster like in Japan, Fukushima reactor, the amount of energy deposited per unit of weight of human tissue is called radiation absorbed dose, which in SI units is called gray. And to put things in perspective, 1 gray is actually equal to 10,000 chest X-rays exposed. Now, another term used is CIVIT, and that actually is a biological risk of exposure to radiation, which is measured in terms of this unit, and that deems the risk of injury to your health because of radiation. And we are actually normally exposed to radiation. For example, if you take an 8-hour flight from New York to LA, you get about 0.03 millisievert dose and health risk because of radiation. And during our normal lifetime in a year, everyone is exposed to 3 millisievert radiation dose due to, for example, sunlight, flying, traveling, etc. However, they are scattered over the time. If you get 1 sievert dose acutely in a day, you will certainly get and feel sick. Lethal dose, which is roughly around 4.5 gray and is called LD50, means 50% of people killed in 30 days. And when that happens and people are exposed to radiation, it produces various syndromes, and three most common syndromes in the body are hematopoietic, GI, cardiovascular, and CNS. And today we will try to concentrate more on gastrointestinal tract. So what happens when you, so it's important to, because there are 14 million cancers diagnosed annually worldwide, and it's a growing endemic, rather pandemic, and because by 2030 there will be more than 223 million cases of cancer. And in UK only last year there were 350,000 new cases of cancer, and more than 36% were related to abdominal cancers. And in that group, 35,000 patients have radiotherapy as primary or associated with chemotherapy as a part of their treatment pathways. So that has a significant impact because there's a global burden of radiation-induced bowel injury in making, and also in future, as this can present up to 30 years from primary exposure. So what's the pathogenesis of radiation-induced injury? And the basic thing to understand is the rapidly dividing and undifferentiated the cell is, the more and the most radiosensitive it is to injury. So for example, your stem cells or your erythropoietic cells in the bone marrow or intestinal cleft cells, which has also stem cells, are most radiosensitive. However, differentiated and less dividing the cells such as hepatocytes, neurons, erythrocytes are actually radio resistant and last to get hit because of radiation. So what happens when your body is exposed to radiation? There are various mechanisms proposed for radiation-induced injury to the body, which includes direct damage to DNA, as well as havoc caused by radiation in cytoplasm called radiolysis. It produces superoxides, injury to mitochondria, ribosomes. It induces apoptosis, and in long term also accelerates aging. It also altered coagulation and cytokine regulation. Concentrating on GI tract, as I explained earlier, GI tract is long and starts from mouth to the lower GI, and your effects of radiation will depend where the injury is. However, we will concentrate on our small bowel, which is made of villi, and in villi have crypts, which is our crypt shown on the healthy gut. The bottom end of the crypt has got green cells or stem cells, which grow in a day and make mature surface cells of the epithelium. So gray cells are mature cells, which are less dividing. The bottom cells are dividing and immature cells, and they contain microorganisms in the gut in control and helps in nutrient absorption. So what happens when there is acute injury because of radiation? As I said, the undifferentiated stem cells are at the base, and the green ones, the large stem cells get the hit, they get dead, and before they get time to recover, there's a disruption in the basement membrane. The microorganism, which in fact our body has 100 trillions of them, start getting an opportunity to invade the body and the vessels, and they invite inflammation. The blood cells get leaky, inflammatory cells all around the place, which further causes the cell injury and death. However, at the same time, the repair mechanism where large stem cells, which are indicated by yellow, also kicks in and starts the repair process. And if the radiation is not intense or is stopped, then the crypt cells repair themselves in a day or two. And that's why it's important to give interval between the radiation, and lower the dose, the better is and quicker the recovery is. However, this produces injury, which can manifest in various forms, such as erythema, ulceration, painful lesions, diarrhea, etc. Due to some mechanism, it also kicks in a process which leads to chronic epithelial injury by the way of inviting fibroblasts, which secretes the tumor growth factors, which induces fibrosis and collagen deposition, which leads to the process of chronic injury, manifest by strictures, lymphangiectasias, loss of organ function, and an injury, an insult, which can even manifestate from 3 months to 30 years later after initial injury. So how to classify radiation injury has been classified into acute, which is within 3 months of body exposure to radiation. About 90% of the people will develop acute symptoms, which can vary from diarrhea to pain to bleeding. And then they enter into a phase where there's a complete or partial resolution of symptoms. A majority of people will feel better. However, then they'll lead to a chronic phase or a chronic radiation injury, which lasts from more than 3 months to decades. And about 90% of people entering this phase will have some permanent change in their bowel habits, 50% of which will develop symptoms which actually significantly affect their quality of life, and 2 to 10% develop severe radiation-induced bowel injury, which actually requires surgical treatment in 30% of the cases, and the surgery is associated with high risk of mortality or morbidity. So why do people get GI symptoms, which is quite evident by now? When radiation, I've explained, causes cell death, which leads to loss of GI physiological function, and that loss manifests into symptoms depending upon the affected site. So if you have a radiotherapy for head and neck cancers, you get mucositis, salivary glands get affected. If it's chest radiotherapy, you get esophagus, which is in line of injury. You get heartburn, you can get dysphagia, you can get odonophagia. Similarly, if the stomach is there, you get nausea, vomiting, pain, and so on. However, this is an important slide which explains when insult happens, there's a loss of cell. The loss of cell means loss of function, and the GI tract, especially small bowel, has various functions, which includes carbohydrate metabolism. When the cell is lost, this leads to malabsorption, which also is associated with fat malabsorption. Fat malabsorption causes vitamin malabsorption. Bacteria get opportunity to get overgrowth. Similarly, disruption of cell leads to bile salt malabsorption, which produces diarrhea. As I'll explain it, also the radiotherapy also causes changes to nerve endings. They get visceral hypersensitivity, neuropathy, and the muscles get dysfunctioned as well. This all produces the syndrome of radiation injury by altered microbiota, altered motility, loss of sphincter control, and chronic pain syndrome because of visceral hypersensitivity. Not to be forgotten is pancreas, which will also get insufficient. And hence, this is all enough to cause diarrhea, and these all mechanisms have been studied during and after radiotherapy, as well as chemotherapy. Lactose intolerance during radiotherapy, 50% of the cases look at bile salt malabsorption, and rapid bowel transit is an important reason for diarrhea in these patients, which persist even after the radiotherapy is stopped. And it's just not purely diarrhea, although it's more worrisome and acute symptom. They get a variety of symptoms, which can vary from pain, agonizing bloating, incontinence. A majority of people get flatulence, which can be very annoying and affecting their quality of life. They could have disturbed sleep because of nocturnal defecation. Also, tenesmus and urgency makes them housebound and reluctant to go out with their daily activities of life. So all these bowel salt malabsorption, small bowel bacterial growth, these all produces symptoms. And can we guess which pathophysiological mechanisms just because on the basis of symptoms? No, it's not possible, because all these different mechanisms have same symptoms. And I think we need test. And this is proven that GI physiological model suggests guesswork for cause of GI symptom doesn't work, and you need to test, and a battery of tests, and sometimes those tests needs to be repeated again and again. Hence, you need a systematic and multidisciplinary approach. And symptoms also are not useful guide in type of endoscopy you need to do. Hence, serial endoscopic examinations are all of reliable diagnostic value. And endoscopy is investigation of choice when you're trying to investigate these people. It can be done very early, and if necessary, it needs to be repeated. You need to have a systematic approach. You have to do an upper GI endoscopy. You might have to do biopsies and duodenal aspirates, and you have to culture microbacteria microbiology cultures as well. Sigmoidoscopy is initially the test of choice, as colonoscopy can lead to perforations easily if the bowel has been affected due to ulcerations and edema. So how we can optimize our patients and prevent this injury to the bowel? And obviously there's various factors. One of the main factors is radiation dose, type of radiation instead of external beam radiation. It could be just localized brachytherapy. So you need to have good radiotherapy services. You have to invest in modern machinery. Schedule of radiation and interval in between the doses is important to give time to recover. And also the volume of intestine involved during the radiation field is directly proportionate to the symptoms produced. For example, radiation done with full bladder pushes the bowel up and less likely to put at the risk of radiation injury. And that sometimes is a protocol in radiotherapy to ask people to drink plenty of water before they come for radiotherapy. Similarly, if they have a history of previous surgery, they develop adhesions, hence the bowel is fixed and more resilient to move, increasing their risk of radiation-induced injury. Then you have to optimize the risk factors such as diabetes, hypertension, arterial diseases, which increases the risk of the radiation injury. Smoking itself is an independent factor, so you should counsel patients to give up smoking before they come for radiotherapy. If they have a history of significant inflammatory bowel disease, then that could sometimes be a relative contraindications for radiotherapy as they get resilient diarrhea and flares. BMI of more than 30 is protective, hence it's important to have your patients to be reviewed by dietitians and had a good nutritional state. Genetics also play an important role in radiation-induced injury. And more recently, there's been a lot of data about probiotics and certain bacterial types which are more useful for the bowel. Melatonin has antioxidant properties and has been used. Similarly, there was a study published which introduced statins, and especially pravastatin. People on those has less severe symptom. Triamcinolone, hyperbaric oxygen, and toxophylline has also been studied. And people also check HIV and hepatitis B status. They also have links to have a worse radiation injury if they're positive for HIV and hepatitis B. I cannot resist showing you this study which was done by colleagues in North Carolina and in States. And essentially what they found in their mouse models, that the mouse who had a little dose of radiations but had lesser injury compared to the other mouses who have severe injury, they found these three species of bacteria were predominant in these mouse models. And when they cultured their stools, they're related to these three species. What they found out also in their stools, they have more tryptophan metabolites. They also have more short chain fatty acids, as well as gut microbial metabolites produced by these species, which not only help in intestinal recovery, but also has systemic effect on bone marrow, increasing their hematopoiesis and overall increasing the well-being of their patients and recovery. The treatment and management and during acute phase is largely supportive and symptomatic. You have to maintain your fluid, electrolytes, and nutritional support. In chronic phase is more difficult, and hence you need systematic and multidisciplinary team approach. You need a good dietitians. You might want to have low fiber diet. You need to have cyclic antibodies if SIBO is small intestinal bacterial overgrowth is suspected, and if it's a resilient cases, you might end up having surgery in 30% of cases. I would like to have a couple of slides on radiation-induced rectal injury, which is quite common problem, especially due to pelvic and prostate radiotherapy. It's acute, happens in about 40% of cases within less than 6 weeks, mostly rectal symptoms, and is dose dependent and direct mucosal injury is the cause, usually self-limiting. Chronic can happen from 9 months to anywhere to 30 years. And luckily in 1 to 5% of cases, mainly the pathology is due to chronic mucosal ischemia, bleeding mucosal tenesmus strictures can form. Sometimes radiation-induced rectal injury is also due to concomitant injury to GU tract and small bowel and can lead to fistulas. small bowel injury, and small bowel obstruction. I would like to introduce radiation-associated vascular ectasia, which is a term, and it's time to give up on chronic radiation proctitis, which in fact is a misnomer, which implies that there is inflammation in rectal mucosa, which led and still leads to wrong therapy for these patients. In fact, there's no inflammation. There's actually vascular ectasias, which causes chronic radiation proctitis. As previously, people have been using mesalazine, metronidazoles, cryotherapies, lasers for these conditions, even steroid enemas. Because there's no inflammation, they have been ineffective. There's some evidence for use of saccharofate enemas as well as argon plasma laser. So if you have radiation to your pelvic area, within 6 weeks you develop acute radiation proctitis, usually self-limiting, and treatment is mainly supportive. Some evidence of steroid enemas. However, about 3 to 6 months later, about 30% of cases can have chronic radiation rectopathy, which includes RAVE or radiation-associated vascular ectasias. Bleeding is the main predominant symptoms, and stool softening and APC is an effective treatment. More lately, there's adding pyrostat, which is a coagulation agent to APC, also fastens their recovery. Chronic radiation practotherapy treatment is difficult, needs diet and lifestyle changes, and severe cases may require surgery. In the interest of time, I will very quickly go through this case, basically highlighting the importance that radiotherapy is often combined with chemotherapy and increases the incidence of their side effects. This gentleman had squamous cell cancer of the tongue, had a chemoradiotherapy prevented with profuse diarrhea and abdominal pain. This plexusimodoscopy showed this in ulcers. In fact, as all investigations, biopsies, etc., came back as no evidence of Crohn's disease. His steroids were stopped. He deteriorated. Angiograms were normal as well. He was scheduled to have colectomy when our results for CMV came back. The frustrating bit is it takes up to 8-9 days for these results to come back, which there was typical inclusion cell bodies, and the patient actually recovered with hydration and antiviral therapy. So, Mr. President, I would like to conclude that GI symptoms are inevitable and frequent, often transient, but severe enough to impact quality of life. Symptoms have a physiological cause, and it's our job to tease out which physiological mechanism it causes more predominantly. Multiple causes are present. Simple investigations are often productive, and be systematic with multidisciplinary approach. I would like to end my talk with some real-life patient quotes, and this is the one of them, which says, 4 years after pelvic radiation, I'm often in my bathroom in pain, crying either because of diarrhea, constipation, cramping, or sometimes wonderful combination of all three. The last one, which I like, I will just read the last line of this quote, which says, pelvic radiation saved my life. However, it has forever changed my life as well. Thank you very much for your patience listening, and I hope you enjoyed my talk. Thank you.
Hi, sir. Ya Bismillah.
Thank you.
So, Professor Sadiq doesn't require any introduction. If you don't know him, then you don't live on this planet. He is going to talk about obesity and the surgical treatment.
Bismillahirrahmanirrahim. Thank you very much, Amir. I feel like being part of this society now. This is 4th or 5th time I'm with you. Better the slides. Thank you. Thank you. I've been given the task of talking about the surgical management of obesity. Obesity, in fact, is a global pandemic now. It is as bad as COVID-19 is. When I started my training and when I was a medical student, we didn't know much about bariatric surgery. And in fact, when I started bariatric surgery here, we used to put up a little picture on the Facebook showing a portion of the stomach that I have started doing bariatric surgery. And a few of my friends who were doctors, they wrote to me and they said, have you started geriatric surgery? Because they didn't have an idea what the bariatric surgery was. It was there, obesity was there, particularly in the West. But the problem was not many people would come for bariatric surgery because open surgery in a morbidly obese patient was an open invitation to troubles. They would end up with wound infection, with incisional hernias, with a lot of morbidity and, in fact, significant mortality. It was the introduction of laparoscopic surgery which changed the whole scenario. Recovery post-op was very quick. Patient would be discharged home within a day or two. Early return to work within a week or 10 days. And then people started, at the same time, obesity was on the rise as well in the community. Not only in the Western world, but also in our part of the, this part of the world in Southeast Asia as well. We started, the surgeons started the first laparoscopic Roux-en-Y gastric bypass was carried out in 1994. And another procedure called laparoscopic sleeve gastrectomy was an incidental operation which was supposed to be part of a bigger procedure called duodenal switch. But what happened was the surgeon who was operating, when he completed the first part of the operation, which is currently known as sleeve gastrectomy, he was told by the anesthetist that your patient is unstable and come on, close it. So he closed the abdomen, and what happened was 3 months later, he saw the patient in the outpatient's clinic, and the patient had lost significant weight. He waited for another 3 months, and then the weight loss was really, really good. That was in 2004. So sleeve gastrectomy is a relatively new procedure, but till this date, sleeve gastrectomy is the most commonly performed operation, the most commonly performed bariatric procedure for morbid obesity worldwide. Obesity, it affects almost 30% of industrialized world. Now, this is a 2016 study, and that was a survey which has shown 650 million people worldwide, they were obese. And it's not only the adults. In children under the age of 5, 41 million children were either overweight or obese. For us, for the surgeons, when the BMI is above 30, we become alarmed. Obesity can be class 1, class 2, or class 3, which is, class 3 is more than 40. But for bariatric surgeons, we have super obese and super obese. Super obese are the patients whose BMI is more than 50. What we do is we keep these people on a diet for 2 weeks, and you won't believe it that within 2 weeks, their liver shrinks significantly. And that makes the procedure so easy for the surgeon. Lifting up a heavy liver is not an easy task, and that makes the procedure difficult, or the surgeon is struggling. But keeping them on a low-calorie diet, particularly those patients whose BMI is about 50, 60, 70, we have operated on people with a BMI of 78 with good outcome. Now, where is the role of the surgeon now? We don't operate on anybody who walks into the clinic and telling us that I'm obese and I need surgery. No, the patient must go through the non-surgical options first. And these are exercises, to see a good dietitian, strict diet, or currently there are some medications, particularly the GLP-1 agonist, and there is a recent trial on semaglutide that has shown some good results, but the weight loss is only 7 to 10%. It's not compatible with the surgery. Now, what we do is, when these remedies, when they fail, then the patient is a candidate for surgery, for bariatric surgery, which remains the most effective sustained weight loss option. If we compare it with non-surgical options, you might have seen ladies going through a strict diet regime for about 3 months, 6 months, because there is a wedding coming up in the family. But the day the wedding is over, within a few months, they go back to the same weight. But in bariatric surgery is the option, the only option you have where you have sustained weight loss. Now, the number of procedures, as I said, have significantly increased in the last decade. This is 2014. In the USA alone, 228,000 bariatric procedures were carried out. Worldwide, we have about 600,000 bariatric procedures annually. Now, bariatric surgery, it not only helps weight reduction, but it's called a metabolic surgery. Whenever there is bariatric surgery, you will always see with it metabolic and bariatric surgery. It's not bariatric surgery alone. And the reason is there is marked reduction or complete resolution of type 2 diabetes, hypertension, sleep apnea, GERD, and it improves the quality of life and social well-being. Now, we've got two types of bariatric procedure. One is called restrictive, other is restrictive and malabsorptive both. Now, in restrictive procedures, basically you can straightforward that you restrict the amount of food which the patient takes. And sleep hysterectomy and band ligation. These are the two common procedures, restrictive procedures. The good thing about the restrictive procedure is that it doesn't cause significant malnutrition. Now, the malabsorptive and restrictive combined procedures are Roux-en-Y gastric bypass, which is my favorite procedure, one anastomosis gastric bypass, and duodenal switch. Now, this gastric banding used to be very popular about 10, 15 years ago because it was straightforward and it was easy to manage, but it had problems. The patient has to see the surgeon every 6 weeks or either to tighten the band or to loosen it. But the reason it is obsolete now is there were high failure rates and there were high complication rates. The band would either slip down, would cause obstruction, or it would erode into the gastric wall. So the gastric band, apart from a few centers in Australia, I don't think anybody is practicing that anymore. As I mentioned earlier, sleeve gastrectomy, where we remove a part of the greater portion of the stomach here, along the greater curvature, This is the most popular procedure these days. It is technically not a very challenging procedure. The learning curve is not that steep as the Roux-en-Y gastric bypass is. Basically, you remove this part of the stomach and you take it out of the body. Now, the effect of this is, I'll talk about it in a minute. The next procedure is Roux-en-Y gastric bypass. Now, this is a procedure where you make a small pouch close to the GE junction, and this pouch is, the volume of this pouch is about 35 cc. Then you divide the jejunum at about 50 to 75 centimeter from the DJ junction and bring the proximal loop, which is called the Roux loop, and join it to this pouch. Now, the length of this limb is about 150 centimeters. This one. This is called the Roux limb, and this one is the BP limb, biliopancreatic limb. And the whole idea is that the pancreatic and bile, pancreatic juice and bile, they came all the way here, and the food would mix up, and the actual digestion, in fact, starts here. So you got 150 centimeters bypassed, and you got 50 to 75 centimeters bypassed. So nearly 2 meters of the gut is bypassed. Also, we got mini gastric bypass or one anastomosis gastric bypass, which is a little shortcut. And in that, what they do is they just bring up a loop of a small bowel and anastomose it to a bigger pouch, which they create here. I don't practice that I do, but not that much as compared to, because this is not a favorite job. It's being practiced in Pakistan, in Middle East, and a few centers in the West, but not in the USA. Single anastomosis is still not approved by ASMBS. So we restrict ourselves either to sleeve or Roux-en-Y gastric bypass. Duodenal switch, SASI, SADS, these are other procedures, bariatric procedures, which are not commonly performed. I mentioned about the history of sleeve gastrectomy, how it started. Now, how does it affect the metabolism of the body apart from restriction? Now, ghrelin is the hormone which is secreted by mainly by the fundus of the stomach. So, bariatric surgeons, we have got to do with two main hormones. One is hunger hormones, that is ghrelin, and the other one is a GLP-1, which is the satiety hormone. So what happens is, as a result of bariatric surgery, there is decrease in ghrelin and there is an increase in GLP-1. So the patients loses their appetite to a significant degree. They don't have that craving for food, and that's why the amount is restricted, so is the appetite depressed. Now, what about Roux-en-Y gastric bypass? It is restrictive and malabsorptive procedure. Restrictive because you got the small pouch here. And malabsorptive because, as I mentioned, you got about 2 meters of the proximal gut, which is not actively involved in the digestion and absorption of food. The next thing is, I mentioned about the ghrelin and all. Now, Roux-en-Y gastric bypass remains the gold standard bariatric procedure because it's a compromise between a very, very malabsorptive procedure called duodenal switch and a restrictive procedure called sleeve gastrectomy. So this is a good compromise, and it is a procedure which is almost more than 60 years old. That's why there is a very good track record of the safety record of the procedure. It was first performed laparoscopic Roux-en-Y. Laparoscopically, it was performed in 1994. In 2015, we did our own, our first Roux-en-Y gastric bypass at Shifa International. We also do sleeve gastrectomies. The number of sleeve gastrectomy is around now almost 5 100, and I've got almost 300 Roux-en-Y gastric bypasses. Now, who should undergo sleeve gastrectomy and who needs Roux-en-Y gastric bypass? Many patients would come and they say, you operated on my cousin and I want the same operation, but in fact, they don't fit into that procedure. So basically, our guidelines are that if the patient doesn't have any significant comorbids, then he or she is a candidate for sleeve gastrectomy. When you need to have duodenal or ampullary surveillance, because you need to have sleeve, other than if you go for a Roux-en-Y gastric bypass, you don't have easy access to the duodenum. Though if patients come with stones in the common bile duct after a Roux-en-Y gastric bypass, we have other means. We go transgastric, get a good endoscopist, and they retrieve the stone for us. Hostile abdomen. Hostile abdomens are those abdomen like patient has had multiple operations on the abdomen. Before there would be dense adhesions, or a patient have a huge incisional hernia. So you would be struggling there to correct those at an operation which in itself takes about 1.5 to 2 hours. So for that hostile abdomen, you need to go for a straightforward job, which is sleeve gastrectomy, or people who can't come for follow-up from remote areas. For them, sleeve is a better option as compared to. And very young patients. I don't offer Roux-en-Y gastric bypass to teenagers or to young ladies who are not married and very young people. Now, Roux-en-Y gastric bypass. If the patient has history of GERD, the sleeve is notorious for causing what we call it reflux. Now, the reflux is increased if the patient is already on medications on PPIs for a long time. So we don't offer them sleeve gastrectomy. They should go for Roux-en-Y gastric bypass. Of people who have multiple comorbids, hypertension, hyperlipidemia, diabetes, these are the patients, these are ideal candidates for Roux-en-Y gastric bypass. Now, revision surgery. If somebody has a sleeve gastrectomy done, and after 5 years, the patient comes back and say, my weight, which came down from 150 kg to 100, now I'm 130 kg again. Now, these are the patients, they need revision surgery, and revision surgery, they should not go for sleeve gastrectomy again, because the results are not that good. They should rather go for a Roux-en-Y gastric bypass, or there are other bypasses which are even better, but with more malabsorption than this Roux-en-Y gastric bypass. Obstructive sleep apnea has a very good outcome following bariatric surgery, whether they do sleeve gastrectomy or they go for Roux-en-Y gastric bypass. In our series, almost 90% resolution of obstructive sleep apnea. Now, inclusion criteria and exclusion, what we do is, in our studies, we included patient with a BMI of more than 30, willingness to undergo surgery, having comorbids like type 2 diabetes, HbA1c more than 6.4, hypertension, sleep apnea, depression, arthritis, low backache. Exclusion were those who had significant illness within 2 weeks preceding surgery, COVID positive patients, pregnancy and lactated mothers, presence of hormonal disorders or history of drug abuse, particularly alcohol abuse. Now, what we did was we looked into our, this is about 100 cases of Roux-en-Y gastric bypasses, and this was about 80 cases of diabetes in our sleeve gastrectomy patients. Now, the follow-up was for the sleeve gastrectomy patients were for 5 years, while the Roux-en-Y gastric bypass patients were for 1 year. What we found was that in sleeve patients, they had a HbA1c on the average, the mean HbA1c was 8.1, while after 1 year, we found their HbA1c was 6.4. After 3 years, the HbA1c fell down to 5.7, while after 5 years, we had almost 88% remission in the type 2 diabetes. And at 3 years, we had 83. And as the time went on, our remission rate increased. Now, looking at their medication regimes, preoperatively, we had 51%, more than 50, they were on oral hypoglycemic, while 30% were on low dose of insulin and 18.5% had a high dose of insulin. After 5 years, we noticed that 62% of our patients, they were diet controlled. Now, 23% they switched to oral hypoglycemics, while 10% lowered their doses of insulin, and only 5% remained on what they were, the same dose of insulin. They were the resistant group. In conclusion, about this, about the sleeve study, we found that there was a remission rate of type 2 diabetes of 46%, 83%, and 88% at 1 year, 3 years, and 5 years. Laparoscopic sleeve gastrectomy is a very effective tool in controlling type 2 diabetes when combined with proper counseling and multidisciplinary approach. The study, which is a retrospective analysis of type 2 diabetes, has shown a better glycemic control in our population as compared to Indian and Chinese population. Now, looking at the 100 patients of Roux-en-Y gastric bypass, now their mean weight was 142 kgs, and we checked their weight 1 week following surgery. And I must remind you that the first 2 weeks after surgery, we keep the patients on liquid diet, and that is clear liquids for 2 weeks. And the patient, most of these patients, they lose significant weight in these 2 weeks. So in the first week, the BMI came down to, the mean weight came down to 134 kgs. After 6 months, it came down to 113, the mean weight. And after 12 months, it was 93.78. Hypertension in Roux-en-Y, out of 100 patients, 66% were hypertensive patients. So 59% were on a single antihypertensive, and 33% were on dual antihypertensive, while 10%, more than 10% were on multiple antihypertensives. Now, this was no hypertension was noted after 1 year in 68% of patients. Their hypertension was fully controlled without medications, and the diet control group had 6%, while 18% had to reduce number of drugs. I mean, those who were on 3 antihypertensive, they came down to 2 or 1, while 7.5% had a persistent hypertension. There was no effect on bariatric surgery whatsoever on their blood pressure. Now, comparing our HbA1c post Roux-en-Y gastric bypass group, their pre-op HbA1c was 8.1, while after 1 year, it came down to 5.9. That was the mean type 2 diabetes. Out of 100 38% were diabetic. I'm sorry. Now, drugs of medication, oral hypoglycemics, they were 54%, while low dose insulin was 13.5%, and high dose of insulin was 32%. So what happened? After 1 year, we had a dietary control of 67. There was switched to oral hypoglycemic 21%, while decreased dose of insulin 5.4%, and persistent or staying on insulin or no response to bariatric surgery 5.4%. In conclusion, bariatric surgery is the only long-term solution of weight loss and resolution or control of comorbidities like type 2 diabetes, hypertension, sleep apnea, osteoarthritis, backache, and of course, PCOS. We have shown excellent outcome of bariatric surgery with minimum complications and high level of patient satisfaction. We would recommend bariatric surgery for morbidly obese patients, those with and without comorbidities. Thank you.
Thank you, sir. So our next colleague as speaker is Dr. Nadeem Tehami. He'll be speaking on optimal hepatobiliary-pancreatic endoscopy post-bariatric surgery. He'll be joining us online.
I am with you. So the first question that we ask in pandemic days is, are you guys able to see my slides and hear me clearly? Clearly not.
We can hear you, but can't see your slides. We need to stop sharing the previous presentation. Thank you.
So let me try again. So could I please request the moderator to confirm if you can see my slides and hear me? Sir Rao Saad, are you there?
You can share your screen now.
Okay, let me just try once again. Okay, could you please confirm if you see the slides?
Dr. Nadeem, can you hear us?
I certainly can, but can you guys see my slides and hear me? If you do, then please confirm.
Hello.
Good morning, Nadeem.
Assalamu alaikum and good morning to everybody.
Nadeem, we can't hear you. Sorry, you're not audible.
Let me try again. So could you please confirm if you can see my slides?
We can hear you now, but can't see your slides.
Let me try one more time. Am I audible? And can you guys see my screen now?
Yes, you are audible, but we're trying to figure out how can we see your slides.
May I ask if any of the other colleagues on Zoom are able to see my slides?
Yes, we can see your slides on Zoom.
Oh, excellent. Okay. So it appears that colleagues on Zoom can see my slides. And I believe they can hear me. That's why they've answered the question. Let's hope the colleagues in the hall can see my slides. Otherwise, I guess I'll have to ask you all to join the Zoom session then.
Nadeem, we can't see your slides on this forum, PSG forum.
Apparently, colleagues on Zoom can see my slides.
That is true, but
I have shared my screen on Zoom, so it should work. I'm not sure what could I do from my end to make it work.
Okay, just a minute. Just.
I'm extremely sorry. Unfortunately, these technical glitches can sometimes be unavoidable, but I believe I'm very well versed with the Zoom platform as we've done several presentations in the past.
No, it's perfectly fine. We are grateful you're awake so early in the morning for us.
Well, I'm gutted that I'm not there, so it's shambolic. I'm missing you all and the homeland. But this is a new world order, so let's hope it works.
Yeah, can't afford to miss your presentation.
Said Saab, can you see the slides on Zoom?
So, not yet, I guess.
Nadeem, can you change your slide, please?
I certainly can. Let me see. Can you see
Yes,
the next slide?
it's fine now. We can see your slide.
Okay, so I'll switch off my video just in case if there's a problem with the technology. So I hope you can see my first slide. So shall I begin?
Yes, Nadeem, we can see your slides. So please start. Thank you.
Okay, thank you very much. Assalamu alaikum. Good morning, everybody. I'm very grateful for the invitation, especially the organizer and Professor Masood Sadiq. My task is to talk on the optimal HPB endoscopy post bariatric surgery. I'm a consultant in hepatology and pancreatobiliary medicine based in Southampton. So I bring you greetings from Southampton, a town that crewed a ship that sailed to a disaster that became a legend. And I hope in years to come, we will be sharing the stories of COVID with our grandchildren. The outline of my talk is to talk about HPB endoscopy, but I will restrict the talk mainly to ERCP. I'll share a case vignette. We'll talk about post-surgical anatomy after bariatric operation, which has nicely been covered by our previous speaker. We will then discuss some of the approaches to gain biliary access and therapy. So the demand and provision of bariatric surgery is continuing to rise with more than 5,000 bariatric operations performed per year in the UK between 2012 and 2016. And more than 150,000 annually in USA over a similar period. As a result, there's a growing cohort of individuals with altered upper GI anatomy. Up to 50% of these undergoing bariatric surgery required subsequent cholecystectomies for symptomatic gallstone disease. EASL state that up to 16% of these patients with gallstones may have concurrent bile duct stones. But interestingly, EASL does not advocate prophylactic cholecystectomy. Now, I don't know what ASLD and APASL say about it, but that's the statement from EASL. ERCP, as we all know, is a standard procedure for biliary intervention, but endoscopic access to the second part of duodenum may be challenging or impossible after certain types of bariatric surgery. Let me start off by sharing a case. So this is a case from a pre-COVID era of a 57-year-old lady who presented to us with upper abdominal pain. She had a previous Roux-en-Y gastric bypass over 10 years ago. She also had a cholecystectomy and was under our care for NASH and NASH-related cirrhosis and portal hypertension. In the past, she's had an episode of decompensation. She has bled and required embolization in coils of her gastric varices. She then had refractory ascites and a TIPS was placed. At the time of presentation, she was hemodynamically stable and she was apyrexial. She had routine blood tests performed, which showed that she had elevated bilirubin with obstructive pattern. Her inflammatory markers were within normal limits. She had hepatic coagulopathy and thrombocytopenia. So she went on to have imaging, which demonstrated choledocholithesis in a dilated CBD. The question at this stage, when she was referred to us, was if conventional ERCP is possible. And unfortunately, we can't have an interactive session. But we then thought at that stage that that wouldn't be possible given her altered anatomy. And we considered some other options, including laparoscopic ERCP, as mentioned by Professor Sadiq during the last talk. We also considered some other options, which I'll discuss during the second part of my presentation. So choledocholithesis, we know that up to 25% of patients undergoing weight loss surgery develop gallstone disease. The range is between 12 to 36 in literature. Decreased rates are observed in patients taking ursodeoxycholic acid, but this is not something we advocate routinely. About 5 to 10% of these develop choledocholithesis, and these patients are the one who we see for ERCP and find access challenging. Bariatric surgery, again, nicely covered by our previous speaker. We discussed Roux-en-Y gastric bypass, sleeve gastrectomy, laparoscopic adjustable gastric bands, which seems to be the common approach, and approaches which have fallen out of favor include vertical band gastroplasty, biliopancreatic diversion, and duodenal switch. So laparoscopic adjustable gastric bands A silicone band is wrapped around the gastrocardia, creating a small gastric pouch with narrow outlet. The band tightness can be adjusted by inserting a needle into a reservoir embedded in the gastric wall. A duodenoscope can usually be passed through this band without difficulty. But if there is a hold up in the band, then it can be released and it can be dilated. Conventional ERCP is rarely limited. It is important to remember, as again mentioned very nicely by the previous speaker, the bands can cause dysphagia, reflux, erosion into the gastric lumen. Therefore, while we're advancing the scope from esophagus into the stomach, we've got to be a little careful. So sleeve gastrectomy, where a small residual gastric pouch in the form of longitudinal portion of the stomach is created. The greater curve of the stomach is removed, leaving residual portion containing cardia, lesser curve pylorus. Biliary access via conventional endoscopic approach should not be affected. It is important to remember that with a very long staple line, there's a high risk of leaks, fistulas, and stricture. Roux-en-Y gastric bypass, this surgery involves exclusion of majority of the stomach with small residual gastric pouch remaining in continuity with the esophagus. The residual pouch is anastomosed to a loop of small bowel with a second anastomosis further down the small bowel, and therefore linking a further length of the small bowel back to the duodenum. The excluded stomach remains in normal continuity with the duodenum, and in these cases, the access to duodenum and therefore biliary tree via conventional per-oral endoscopic approach is not possible. So this diagram will essentially demonstrate that access becomes challenging post-gastric bypass. So in terms of when we talk about the therapeutic intervention, Roux-en-Y gastric bypass presents a particular challenge. There are different options available, including per-oral endoscopy assisted and endoscopic ultrasound assisted, or surgical, and that is laparoscopic assisted ERCP, and percutaneous approaches. And these all are effective and safe options. But these options should be carefully considered with a specialist MDT, and one should be mindful of surgical details and the available expertise. As far as the lap-assisted ERCP is confirmed, is performed as a combined procedure involving endoscopist, surgeon, procedures performed in operating theater with X-ray screening, endoscopy stack, standard duodenoscope with GA, and patient lying in a supine position. During laparoscopy, stomach is identified and secured to the anterior abdominal wall using a 15 to 18 millimeter gastric port and pursing sutures. The duodenoscope is then inserted via the port into the gastric remnant. And from there onward, a standard ERCP technique is performed once the scope is in the duodenum. Now, when we are planning a laparoscopic assisted ERCP and to aid the insertion of the duodenoscope into the duodenum, we request our surgeons to insert the gastrostomy port as far from the pylorus as feasible. This is to avoid the sharp angulation of the duodenoscope to allow duodenal access. It is most commonly done through the gastric remnant, but can be done through the biliopancreatic limb. But we tend to discourage it. There's only one case I remember where we went for this approach and really struggled. One of the disadvantages of this technique is that post-procedure closure of the gastrostomy precludes subsequent removal of endoscopic place stents, or if the patient bleeds, and therefore a patient may end up requiring repeat intervention, repeat laparoscopy. If the cannulation fails, then at least the advantage is that we are still in the OR and we can use our echoendoscope, or using surgical technique, we can go the rendezvous. With the long scope, one of the major disadvantages is that these do not have elevator. So Roux-en-Y or Roux-en-Y hepatico-jejunostomy both involves creation of a long afferent limb. And then conventional duodenoscope access via the pylorus is not possible. And in cases involving long afferent limb, double balloon enteroscopy can be really helpful. The access to the biliary tree via small bowel afferent limb, depending on the site of ruined by anastomosis, can be up to 200 centimeter long. Therefore, the endoscopist must review the images and operation notes prior to the intervention and should ideally discuss it with the surgical colleagues if possible. With the double balloon and enteroscopy, it requires a dedicated endoscope, long endoscope with a flexible polyurethane overtube. The latex balloons attached to the tip of the endoscope and overtube are filled and emptied with air. This coordinating sequential balloon inflation and insufflation with alternating pushing and pulling maneuver allows the deep enteral intubation into a long afferent limb, which potentially could provide access to the biliary tree. The problem here is the availability of the accessories, as the most equipment designed to use through the duodenoscope may be too short for the longer enteroscopes, or maybe too wider, because the most double balloon enteroscopes use a 2.8 working channel. There are some shorter enteroscopes available which have a bigger 3.2 millimeter working channel, which allows the use of most conventional ERCP accessories. But it can also be hampered by loop formation and surgical adhesion, which tends to limit the maneuverability. Likewise, the single balloon enteroscope assisted to achieve the stable position, we tend to angulate the tip or use the suction. It has the obvious benefit of requiring less time to set up. And then the angulated tip may at times make the passage through the anastomosis and loops easier. With the spiral enteroscopy, it involves use of rotating overtube to pleat the small bowel over the enteroscope, facilitating the deep intubation. But what tends to happen is the anatomy, understanding of the anatomy is incredibly challenging. And therefore, consultation with surgical colleagues and reviewing the notes tends to guide us better. And then the challenges are once we get there, so we know it's much easier if you've got a typical orientation where we are approaching the ampulla from underneath. But in these cases, you may have to consider cannulating in the reverse direction. And so sometimes you have to maybe reverse the sphincterotome as well. If you look at the data available comparing the lab versus enteroscope-assisted ERCP, lab seems to be most favored. The meta-analysis available tends to support that cannulation rates are better with the lab-assisted ERCP. The complication tends to be higher with the laparoscopic-assisted ERCP, but I guess most of these are attributed to the laparoscopic part of the procedure. Direct ERCP-related complications appear to be similar both in lab-assisted and balloon enteroscopy ERCP. Let me just share this recent retrospective study where they compared lab ERCP with balloon enteroscopy ERCP in patients who've had previous Roux-en-Y gastric bypass. They essentially found similar success rates between the two groups of 87 versus 72. And then the complication rates were also pretty similar. But what they observed that the success rate significantly improved in both modalities from the first quarter of patient compared to the last quarter, which possibly suggests that the endoscopist experience has a significant impact on the success rate of these procedures. Now, I hope the younger audience will be able to recognize Mr. Edge. And what we do with the Edge is that with the endoscopic ultrasound, the excluded stomach is identified from either the remnant stomach or the jejunal limb beyond the anastomosis. And the excluded stomach is then accessed with an EUS needle. A contrast agent or with water is injected to confirm the position and to expand the excluded stomach. So we essentially convert into, make it like a pseudocyst. And then a larger diameter, 2 centimeter diameter, preferably lambs, is inserted over a wire. Now this can be done freehand, and then this creates a conduit between the remnant stomach or the jejunum and then the excluded stomach. The proximal end of the lamps can be secured in place using clips or endoscopic sutures. So there is a new stent available recently, which is over the scope stent fix. The lamps can also be dilated, but we tend not to advocate this. So this fistulous track through the lamps, which we in our practices, we tend to let it mature for a week or two, which can then be used for conventional ERCP. And once the ERCP is completed and the access is no longer required, then the lamps can be removed, and the defect we can either leave it to close spontaneously, or it can be closed using over the scope clips. Important thing is to mention and to reassure our bariatric surgical colleagues is that leaving the lamps in place has not been shown to cause the weight gain. Based on the available data, so there are different ways we can approach the excluded stomach. The therapeutic success appears to be consistently above 90%, with the complication rates ranging between 10 to 24%. There is a data, a pair which showed that EDGE is technically non-inferior. It has a similar level of adverse effects. It provides a shorter duration of stay in hospital, procedure is shorter, and it appears to be more cost effective. This slide taken from Boston Scientific essentially just shows that this cautery-enabled access catheter with the therapeutic access, and we create anastomosis between two structures. And there are different techniques described, but as I've mentioned, once we have identified the stomach, inflated it with fluid in making it like a pseudocyst. And then once the anastomosis is established between the remnant and the excluded stomach, and the conduit established, that can then be used for a conventional ERCP. In terms of the percutaneous approaches, this is a non-endoscopic antegrade approach to the biliary tree. It's usually performed by the interventional radiologist, and it is required when endoscopic approaches have either failed or deemed not possible. And in this, under endoscopy, under ultrasound, under fluoroscopic guidance, the intrahepatic biliary tree is punctured with a needle, a wire is passed, and subsequent drains are inserted. This then allows a direct visualization of the intraductal stones or strictures. There is this recently developed a shorter cholangioscope, which is a 10.5 French spyglass discover scope. This can be inserted down a 12 French percutaneous transhepatic sheet. It could be challenging in cases when the intrahepatic ducts are not dilated, or if there are strictures, and in cases where patient has ascites or coagulopathy, which cannot be corrected. So if I take you back to our case, so this lady, we thought about balloon enteroscopy assisted ERCP. Unfortunately, we did not have the right accessories available. Therefore, this was not an option for our patient. The next question was, we went to our surgical colleagues asking if laparoscopic ERCP was possible. However, they were concerned given her portal hypertension, coagulopathy, and small amount of ascites. So therefore, that option was also excluded. We then approached our interventional radiology colleagues, who were again not convinced, again, given that she had the intrahepatic ducts were not dilated, there was some perihepatic fluid, and with the hepatic coagulopathy, there was also a concern that any intervention would lead to hepatic decompensation in this case. We were then left with the only option, and that was to just try it using Mr. Edge. And what we did in a two-step procedure, we identified this flower-shaped stomach. It was accessed via EUS scope. A large amount of water with contrast injected into the excluded stomach. We then placed an axial stent, And about 10 days later, we went in with the conventional duodenoscope and cleared her ducts. So in terms of the limitation, I've already mentioned that EASL does not recommend cholecystectomy with bariatric surgery, despite being evidence shown of a high risk of stone formation post bariatric surgery weight loss. We know that these different options, including laparoscopic, bile duct exploration, and stone clearance, could be effective and achieved if gall bladder is in situ. The available data most is retrospective, single center, and single operator cohort studies. And these reports, most of these reports are non-randomized, and there is a significant heterogeneity exists in the reported success rate between different researchers. So this is a modified algorithm. This mainly talks about different approaches. So for example, if our patient was septic, then the option would have been to deploy the stent, fix it either using sutures or stent fix, dilate the stent, and try to clear the CBD in single setting. Clearly, this carries more risk compared to a two-step approach. But the important bit again, and that is to reassure our bariatric surgeons, is that once the procedure is complete and the stent is removed, weight gain does not seem to be a problem in this group of patients. So in summary, with the gastric bands and sleeve gastrectomy, conventional ERCP is possible. With Roux-en-Y, we have different options available, which should be discussed with the local MDT. In terms of non-bariatric approaches, there are, again, similar options which can be discussed with the MDT. So in summary, Mr. Chair, ladies and gentlemen, choledocholithiasis is common post-bariatric surgery. Conventional ERCP may not be possible, especially in Roux-en-Y, which poses a particular challenge. We therefore have to carefully consider our options with our MDT, and we shouldn't try to jump without parachute. Therefore, be mindful of surgical details and the available expertise. Thank you very much.
their flights. So we have 6 prizes to give away. Further announcement is that after this prize distribution, there will be a tea served for a very short period. We're running late, so we'll have tea served only for 12 minutes, and the trays will be closed down after 12 minutes, and you'll come back for the next session. The faculty to stay back while the rest of the people go for the tea. Okay, so may I request Professor Zegam to please come over and distribute the prizes.
Anisha Kamani.
Second prize for poster presentation goes to, this is by the way, 10,000 cash. The second prize goes to Shayan Ali.
Shayan Ali Saab.
That is 20,000 cash. I can keep it if you don't want it. The first prize goes to Mr. Dr. Lashpat Rai from Karachi, 30,000 cash. For the 3 paper presentations, the third prize goes to Hafiz Haris, 10,000 cash. Second prize was won by Dr. Faiza Sadakat Ali. That's a cash prize of 20,000. The first prize was won by Dr. Laima Alam. She is not presently here. She called me. She'll come and collect it from me later. But Dr. Laima Alam, 30,000 cash. That's her prize. Thank you, Arun. Tea for 12 minutes, please. Okay, so we start with the last session of this Congress. And this session will be chaired by Dr. Akif Dilshad, Dr. Akif Dilshad, Dr. Asim Anwar, Dr. Masood Siddiq, Dr. Akif. Sir, you're supposed to be the chair of this session. Yes, sir. A bit of hepatology now. Our first speaker is going to be Dr. Zaigam Abbas from Karachi, and he's going to talk to us about chronic suppression of hepatitis B virus and its implications.
Bismillahirrahmanirrahim. Thank you very much for inviting me to be here physically, and I am enjoying the meeting as well as the nice weather in Islamabad. So I would be discussing the long-term suppression of chronic hepatitis B infection. Nothing to disclose. So treatment that we have at this point in time for hepatitis B, we are only able to partially cure hepatitis B. We are able to suppress hepatitis B virus DNA, and we are able to convert hepatitis B E antigen to E antibody in many cases. But unfortunately, we are not able to get rid of hepatitis B surface antigen. We can achieve this only a very small fraction of the cases. The complete cure, which is no cccDNA and no integrants, we are not able to get this with the current treatment. In any case, our goal is to prevent cirrhosis, hepatocellular carcinoma, and death. So as we know, there are different phases of hepatitis B virus infection, and we have hepatitis B immune clearance phase, and then we have the hepatitis B E antigen negative phase, and in both of these phases, ALT is elevated and HPV DNA is elevated. So current guidelines suggest that we should treat both of these phases. We are not treating immune tolerant phase at this point, and we are not treating inactive carriers. So why we want to treat our patients with hepatitis B? Because we want to prevent progressive fibrosis. So what are the risk factors for progressive fibrosis? Male sex, increasing age, metabolic syndrome. If this is there with hepatitis B, then the pace of fibrosis increases. Alcohol consumption, co-infection with the hepatitis C, D, or HIV, and elevated ALT. So these are the all factors that aggravate and accelerate the process of fibrosis in patients with hepatitis B. Other factors that are viral related include HBV DNA and hepatitis B E antigen positivity, and perhaps genotype also matters. So we have anti-cover and tenofovir. We do not use much pegylated interferon because we have genotype D, which responds poorly to pegylated interferon in Pakistan. And we cannot use pegylated interferon in cirrhotic patients in advanced fibrosis and decompensated cirrhosis. So as I mentioned that when there is elevated ALT, which we see in patients with active phase or E antigen negative hepatitis B, this is associated with progressive fibrosis, and the pace of fibrosis increases with elevated ALT. Not only elevated ALT, but HPV DNA also does matter. That's why the guidelines show that if the ALT is elevated and HPV DNA is elevated, you should treat your patients. The risk of cirrhosis increases with elevated HPV DNA, and risk of hepatocellular carcinoma also increases. Greater the HPV DNA, more is the chance one will develop hepatocellular carcinoma. So if we treat our patients with hepatitis B, so long-term treatment is associated with decrease in the progression of disease, decreased risk of decompensation, and decreased chances of getting liver transplants. So many of these patients may get off the liver transplants list. There is reversal of inflammation when we treat these patients with tenofovir, and it has also been shown there is regression of fibrosis and cirrhosis in these patients. Not only with tenofovir, but studies are also there with anti-cover, where there is reversal of inflammation and regression of cirrhosis and fibrosis. So if you are able to implement hepatitis B treatment programs, so here I am talking about treatment, not the prevention. So even the treatment programs, if you see that you are able to decrease SCC mortality through national viral hepatitis therapy programs, and this is an example from Taiwan that they have shown that liver-related outcomes can be decreased if you are treating your hepatitis B patients. So this is a retrospective study in which 20,000 patients were recruited. 11% of these patients were cirrhotic patients, and 17,500 had the complete suppression with hepatitis B therapy. 376 lost their surface antigen, and when there was viral suppression, the incidence of all outcomes, including decompensation, liver transplantation, and liver-related mortality, decreased significantly. There was also decrease in the SCC incidence, but for SCC incidence to decrease significantly, it is important that one should have a loss of hepatitis B surface antigen as well. So this is a graphic presentation that shows that hepatic events, liver-related mortality, and HCC all decrease if you suppress HPV DNA, and if you are able to suppress a hepatitis B surface antigen, the HCC incidence further decreases. So when you are treating your hepatitis B patients, you may not get the significant results in the first 5 years of a decrease in the incidence of hepatocellular carcinoma in cirrhotic patients. But if you continue treatment in the long run, it is clear that after 5 years, the benefits of long-term therapy become more evident in cirrhotic patients with hepatitis B. So if you do not treat your patients, what happens? As this has been shown in different studies, that some of the patients you do not treat because guidelines do not suggest to treat these patients. If you leave these patients without treatment, then the risk becomes of hepatocellular carcinoma much more as compared to the patients who are being treated according to the guidelines. So these are studies. Then question either whether to give tenofovir or anti-cover. So there was some initial concern that tenofovir expresses more hepatocellular carcinoma formation as compared to anti-cover. But later on, this became clear that if you adjust your variables with age, sex, country, albumin, platelets, alpha fetoprotein, cirrhosis, and diabetes, then both drugs are equally effective. And this is also evident from the data that has come from Europe. So we have to keep our patients on long-term suppression of HBV DNA to reduce the risk for hepatocellular carcinoma. And this is the meta-analysis which shows the cumulative risk of 2.8% in the treated patients as compared to 6.4% in the untreated patients. So what are the successes of long-term suppression with current hepatitis B virus monotherapy? There are excellent virologic biochemical responses. Progression to cirrhosis is prevented, and in some cases, you are able to document the regression of cirrhosis. Decomposition is prevented and improved, and there is improvement in fibrosis, portal hypertension, and overall survival. Hepatocellular carcinoma incidence risk is decreased, though this is not abolished, because with the current treatment, we are not able to suppress effectively hepatitis B surface antigen. But there are limitations with long-term suppression with current hepatitis B virus monotherapy. There are safety issues with tenofovir in the long-term therapy, especially the creatinine clearance and osteoporosis that may be there. So now there are improved forms of tenofovir, which is alafenamide therapy. Partial viral response is seen in highly viremic patients. Some of these patients, we are not able to fully suppress the virus. The risk of residual hepatocellular carcinoma remains there, even with a long-term therapy, because this therapy is not able to get effectively suppress hepatitis B surface antigen, because there are low rates of surface antigen loss. We are not able to eradicate cccDNA or integrated HPV DNA, and long duration of therapy is required, resulting in high cost, potential drug resistance, and prolonged adverse events. So here comes the issue that immunotolerant patients who have the normal ALT, but they have the elevated HBV DNA virus, much elevated. Why do we not treat these patients? Because as I mentioned, that HPV DNA viral load is directly related to hepatocellular carcinoma formation. So this is a new debate that what should we do? So there is now some paradigm shift for immunotolerant patients, as I mentioned, and that current guidelines do not effectively address this issue. So this is one of the study which shows that if you treat these immunotolerant patients, you are not able to completely suppress HPV DNA, which is less than 69 international unit per milliliter after 4 years of therapy. So only in half of the patients you are effectively, you are able to suppress effectively. And seroconversion in immunotolerant patients is hardly documented. So they remain E antigen positive most of the cases. But the good thing is that you are able to suppress HPV DNA, and there is much log reduction in the viral load. So there are arguments against treating immunotolerant patients. As I mentioned, there is very low hepatitis B E antigen seroconversion. Indefinite treatment may be required. Virus suppression may not be complete. There is a possibility that if you keep on giving drugs, patient may develop resistance. What are the safety issues of long-term therapy with antiviral therapy? With the antiviral therapy, as I mentioned about tenofovir also. Patients do well in the short term and intermediate term, even without treatment. Then why to put these patients on the treatment? There is not enough evidence that long-term outcomes may be altered with the treatment, and the therapy may be expensive. But if you see the other side of the coin, that this is a study, which is the study from Korea, in which they have seen patients who are the immunotolerant patients. Immunotolerant means high viral load but normal ALT. If you compare these patients with the patients who are actively treated, you can see that the incidence of hepatocellular carcinoma is much higher in immunotolerant patients as compared to the treated patients. So this makes a point of treating hepatocellular, treating immunotolerant patients with hepatitis B. So there are arguments in favor of immunotolerant chronic hepatitis B treatment. Though we know that intermediate and short term, there may not be much change, but long term outlook may change. Though we are not certain, but I have mentioned that long term we are able to suppress hepatocellular carcinoma formation. So we have to treat these patients, but jury is still out. And many of these patients, immunotolerant patients, because they are not in the regular follow-up, they may go in the immune active phase, and active damage may start in these patients. And as we know, even ALT normal patients have advanced fibrosis. So this goes in favor of treating these patients. So last part is when to discontinue therapy. So as I mentioned, the long-term suppression is good for hepatitis B virus patients, but should we continue indefinitely for lifetime? Then there are different guidelines for hepatitis B E antigen positive patients. You have to confirm the surface antigen loss, which is not possible in most of the cases. And second option is you document a E antigen seroconversion from E antigen to E antibody, and then give a consolidation phase. You keep on giving therapy, don't stop the therapy, and then you see, because if you stop the therapy early, then patients will go back into high relapse rates. So to prevent the relapse, it is very important that the consolidation therapy will be given, and this is more so in the patients who are more than 40 years of age. You have to give solid consolidation therapy of up to 18 months, because if you do not give consolidation therapy effectively, even after the seroconversion, then there is a high chance of high relapse in hepatitis B E antigen positive patients. For E antigen negative patients, you give therapy for 3 to 4 years at least, and you document that there is complete suppression of hepatitis B virus DNA, and then you may consider, but you should not try this in patients who are the cirrhotic patients. So what happens if you stop the therapy in these patients? Then there is a flare, which happens to almost all of these hepatitis B antigen positive patients. But in many patients, you see that there is an immune control phase, immune system becomes active, and these patients end up with loss of some of these patients with surface antigen, or they become a inactive carrier. So you had treated your patients for more than 3 years with complete virus suppression, and now you stop. Then after a lag period of 1 to 12 months, then flare occurs in these patients, which is a universal phenomena. And this flare lasts for a few months. Then you have to assess your patients and keep these patients in observation, because 20% of these patients may lose their hepatitis B surface antigen, which is a good sign. Some of these patients, about 40%, may not require treatment, but about 40% would be needing retreatment. So this is another study which shows that if you stop therapy, there is reactivation, but about 19% will achieve hepatitis B surface antigen loss at 144 weeks, which is 3 years after stopping the treatment, and 60% would remain off therapy, but 40% would require treatment. This is a daring study. Here you can see when you stop the therapy, then you have to carefully watch your patients, because after the patients who have the surface antigen loss, you can see in the blue bar, and their number keep on increasing for 12 months, and then you get about 20% loss of the surface antigen. So this is an experiment which may be tried in selected patients. So this is the further details of daring study. So what should be the stopping rule? So a stopping rule is that you have to watch for any flares. You give treatment for 4 years at least in hepatitis B E antigen patients, and there should be 3 years of complete suppression of hepatitis B virus infection, and then you observe these patients, you observe for good flares and bad flares. So good flares are the flares that are going to clear the virus, surface antigen, and bad flares are when ALT is more than 10 times upper limit of normal or for more than 5 times with increase in the bilirubin and prolonged prothrombin time. These are the severe flares. You should start retreatment. Another possibility is that patient may not go into the severe flare, but a patient may become a chronic hepatitis B patient again, requiring treatment. So, concluding my presentation, chairpersons, some take-off messages are there that in E antigen positive patients, patients with advanced fibrosis and cirrhosis require indefinite therapy. And otherwise, if the patient is of less than 40 years of age, patient has not cirrhosis, then greater than 12 months of consolidation should be given after E antigen seroconversion, and then you may consider stopping therapy in these patients, but look for any flares even after stopping therapy in E antigen seroconverted patients. For E antigen negative patients, those who have advanced fibrosis, do not do any experiment, keep these patients on indefinite hepatitis B suppressive therapy. But if the patient is not cirrhotic, patient is young, then keep these patients under observation after stopping therapy, after you have given 4 years of antiviral therapy and 3 years of virus suppression. Then 20% of these patients may lose their surface antigen, and 60% may remain off therapy. For immunotolerant patients, emerging data has made a recommendation of not treating immunotolerant patients controversial, because guidelines do not suggest, but emerging data does suggest that these may be the candidates for future virus suppressive therapy. Diagnostic biopsy may be performed, and if there is F2 fibrosis in spite of normal ALT, and if there is high viral load, these patients should get treatment. Thank you very much.
Second topic is NAFLD, NASH, and Beyond Diet and Exercise by Dr. Shahid Habib. Done. Last.
Dr. Shahid Habib has already done this talk in the morning. So next talk is on hepatitis C elimination, where we stand today. And for this talk, we have got Professor Saeed Hamid from AKU Karachi. And I hope he's on the line.
Yes, I'm here, Dr. Masood. Can you hear me?
Yeah, thank you very much, Professor Saeed. You're welcome.
And can you see my slides? I'm sharing my screen. Can you see my slides? Hello?
Professor Saeed Hamid is the right person to talk on hepatitis C elimination. He has been working on it for the last many years, and there are a lot of publications. And please, Professor Saeed Hamid, go ahead.
Can everybody see my slides? Are they shared now?
No, sir, we can't.
I'm sharing from here, so I don't know. Should I do it again? I'll stop and I will screen again. I don't know what happened here. If not, then maybe you can run the slides from there. I will try once more. Okay, can you see the slides now?
Yes.
No.
Can't see them?
We can see, sir.
Yeah.
You can see the slides. Shall I go ahead?
Yeah, it's okay. It's okay.
All right. Thank you very much, Professor Masood, for the kind invitation. I'm sorry I could not be there in person for various reasons, but I hear it has been a very successful meeting under your leadership, so congratulations for that. So my topic is HCV elimination. Where do we stand today? And I will take, these are my disclosures. I will take an Asia Pacific view more than a national view because we live in this region, and I think there are many similarities from this region. So as we know, hepatitis C is responsible for a fair amount of morbidity and mortality in our region. Nearly 21% of, 21% of global liver cancer deaths are due to hepatitis C, but in Asia Pacific, particularly in East, South, and Southeast Asia, this can go up to 25% of liver-related deaths. In fact, if you look at the countries of high income, which are present in Asia Pacific, places like Japan, Korea, Taiwan, etc., more than 50% of liver cancer deaths are caused by hepatitis C. The reason being that most of these countries have taken care of their hepatitis B because of through vaccinations, and now hepatitis C is emerging as the biggest etiology for liver cancer. So large burden of disease that we have to focus on. Before I move on to what is the current situation in terms of elimination, let us remind ourselves, and people must have seen these slides many, many times before, but just very quickly, these are the global targets that the World Health Organization came up with for 2030. And there are four targets for prevention, one for diagnosis and one for treatment. So prevention is hepatitis B vaccination and hepatitis B mother-to-child transmission by giving birth dose. And both those targets are 90% to be achieved by 2030. As you can see, we are very, very far away, or we were very far away at least at baseline at only 38% for the birth dose vaccination, and only 50% in 2020. Safe injections, there has been some work on this, but we are still yet to achieve 90% safety in injections. And then there are other things like harm reduction in people who inject drugs and so on. Diagnosis-wise, it is estimated that by 2020, we may have reached 30%, but we are certainly very far away from the 90% target of 2030. And hepatitis B and C treatment, although treatment has risen up, 8 million may have been treated by 2020, out of which 3 million are hepatitis C patients. But still, reach 80% of eligible treated patients is far away. So how does this translate into countries on a global scale? This is an analysis of 45 high-income countries across the globe. And what is very clear and sort of disappointing to see is that there are only 12 countries that are on target to eliminate hepatitis C by 2030. And all of these 12 countries are by definition high-income countries. They may not be high-burden countries, but they're certainly high-income countries which have the means and the funding to do this appropriately. Please note that there are three countries, Asia-Pacific countries, Taiwan, Japan, and Australia in this group, which will eliminate before or by 2030. Also note that there are no low-income or middle-income Asia-Pacific countries that are currently on track, and this includes Pakistan, of course, that are currently on track to meet the WHO HCV elimination goals before 2050. So the large majority, as you can see in the pie chart, 62%, will achieve this by 2050, 20 years later to what was suggested. We know that there are major gaps in the cascade of care. We keep talking about this all the time, and this is something that needs to be strengthened more and more. We also know that there are very effective, well-tolerated treatments that are in place, and if we can get people diagnosed and linked to care, then we can certainly make a big improvement in terms of the elimination targets. The key linkage, the key steps are the diagnostics, screening, and diagnosis, and then linking these patients to treatment, which is really not happening in many places at a good rate at the moment. So these are the key challenges that are faced in many countries, including Pakistan. There is lack of reliable epidemiological data, although we probably have better data than some other countries in the region. There is still a large burden of undiagnosed hepatitis C infection, and coupled with the fact that there is lack of awareness of risk factors and transmission. So people don't realize that they may have been infected with blood products or multiple injections or reuse of injections, etc. There is still limited access to care for people who inject drugs, and there is some stigma and discrimination which is relevant for people infected with hepatitis C. And the least of all, and perhaps the last of all, or perhaps the most importantly, financial barriers are there to treatment and care. Having said that, having given you all the negative information so far, there have been significant progress that has been made. And those are in three areas. For example, in the assessment, in the pre-treatment assessment, we have moved away from invasive investigations to non-invasive investigations. Remember that we need to determine whether patients are cirrhotic or non-cirrhotics. Depending on that, the treatment duration is defined and so on. And in this, there has been good improvements, including the FibroScan, including the validation of the non-invasive scores like FIB4 and APRI, which are now recommended by the WHO as good parameters to exclude liver cirrhosis in patients that you're going to treat. So we have tools through which we can make these assessments very, very easily. Secondly, of course, the biggest advantage has been to move away from the injection-based therapy, in some cases for 48 weeks, to oral therapy, which in many cases is 8 weeks, and in most cases is 12 weeks only. And so this has resulted in a lot of pre-treatment and on-treatment simplification. So the pre-treatment simplification is that really you need only two parameters to worry about. One is that you need to confirm viremia somehow by some test, like core antigen, PCR, etc. And you need to determine the presence or absence of cirrhosis. And as we discussed, this can be done now very, very easily and effectively without non-invasive methods. On-treatment simplification is something that is now being purported very much so. The reason being that these drugs are very, very effective, and we have good data from our region, from our country, to suggest that these drugs work in the large majority of patients. This is a study of about 8 or 9 Asia Pacific countries that we participated in also. And if you concentrate on the genotype 3 infection, the rates of cure are very healthy. So if you have SVR in an intention to treat, it is 91%, and in a per protocol analysis, it is 97% of these patients are cured. And this goes across the board. This is SOFWELL, genotype 3 patients from Singapore, even genotype 3 treatment experienced patients and co-infected patients, etc. 99 to 100% with SOFWELL, with virological failures less than 1%. And most of these are non-virological reasons for compliance. Same story for SOFWELL 12 weeks in other parts of the world, so I will not dwell too much into this. So what does this lead to? This is a study which looked at on-treatment simplification. And the simplification was, we've already discussed the pre-treatment one, is on-treatment simplification is step number 2 and 3, that you give your treatment, all 84 tablets, which is 12 weeks of treatment at the same time. So this is just a one short treatment. You give these people 84 tablets, tell them to go home and keep taking these tablets and not come back to the facility. What you do is you maintain some remote contact, and that too also only at these 2 time points that this study did at weeks 4 and week 22, you scheduled an SVR. These implying the fact that we know that these drugs are so safe and easy to use that really there is very little needed in terms of on-treatment follow-up. And this simplifies treatment much further. So out of this 3 major areas of progress, the last one that I want to talk about is the care settings. So traditionally, we have been limited to specialized hospitals in treating these patients, but now there is the move to broad healthcare settings and prescribers. And this is again endorsed by a number of societies, including WHO as a parent organization and other professional societies. So for a clinically well and stable patient who's going to be treated in a primary care facility or a community-based setting, it could be either a physician or a nurse. So it doesn't necessarily need to be a physician. All you need is a clinically well, stable patient, and you give them treatment in the community. Of course, for advanced liver disease and people with other comorbidities like mental health and injection drug use and so on, you need facility-based treatment, and that is a much smaller number. On an average, our patients are about 25 or 30% have cirrhosis, out of which some of them will have advanced liver disease, and they will require a facility-based approach. So this is something that is still really not very much practiced in our setup, and needs to be enforced. There is also post-treatment simplification. This is a data from a study done by MSF in Karachi, in which we also participated. And it just gives you a modeling of cost effectiveness of an HCV screening and treatment program within a primary healthcare clinic in Karachi, Pakistan. So the incidence of cirrhosis goes almost half in these patients. Decompensated cirrhosis decreases, hepatocellular carcinoma decreases, overall liver deaths decrease, and you can decrease by half the daily adjusted life years, disability adjusted life years from 2.26 to 1.23 at a cost which is only $450 per DALY averted, which is a very reasonable cost in terms of the cost effectiveness programs. We also know that we do not really need to follow the non-cirrhotic patients. Only 1.35% prevalence of liver cancer in a 5-year survival in this study. But certainly you need to follow the cirrhotic patients who have particularly not achieved an SVR, because they remain at high risk of liver cancer. So to putting this all together, the viral hepatitis elimination call to action, which is endorsed by almost all professional societies and also by the WHO, is as follows. Simplification, we've talked about. Decentralization, we've talked about. Task sharing, we've talked about. So it is not really physicians. This can be a group of people who can administer and look after these patients. Integration is something which is missing. And what does integration mean? That means integrating the hepatitis C treatment with primary care and with what is called universal health coverage. And if this step is taken care of, I think we will be on our way to elimination. So just to show you some consensus statements from the various societies, and if you read the bottom line, there are virtually no medical reasons to withhold therapy for hepatitis C with these drugs. And simplified pan-genotypic anti-HCV treatments must be used to improve access to HCV treatment and increase global infection cure rates. In fact, now some of the studies are even talking about the fact that we could get rid, the drugs are so effective, one could get rid of the SVR and just treat these patients for 12 weeks and be done with it, assume that they have 97% or 95% have been cured. So we know what is required. We know that there is political drive that is required. We have effective tools, as I have demonstrated to you. If both of these are in place, the elimination will occur eventually, inshallah. What about the political drive? There is global political drive through various organizations like the WHO, like the NOHEP, World Hepatitis Alliance, and like CEVAP. So these are all a few among the many organizations across the globe that work very effectively for elimination purposes. But really, what is required is a national will. And that is the one that is missing from many, many places. For example, our own situation, if you remember, we had a big gathering at World Hepatitis Day at the same place where you're sitting right now in Serena in 2019 with a pledge, 2019, with a pledge to launch a hepatitis C, a massive hepatitis C elimination program in the country. And almost 2 years later, we are still talking about it. Of course, one can exclude the 1 year of the COVID pandemic that we've had, but that is, of course, hopefully behind us soon. If there is national will, this all things can be brought together, because what the national approach will do is develop policy based on data, develop harm reduction programs like free birth dose vaccination and third vaccination coverage, third dose vaccination coverage for hepatitis B, publicly funded screening programs, and free treatment programs for nationals. These are some of the keys that we put together in the Lancet Commission on Elimination that would be needed to do this effectively. But what is the situation on the ground? These are some policy level issues that we saw, that we looked at in this publication. If you look at Pakistan, not doing badly. The green dots are where policies exist. The yellow dots are where policy is in development but is not well applied, and the red ones are where there's no policy. And Pakistan only scores a red in one, which is the birth dose vaccination for hepatitis B. Work needs to be done here. So most countries in Asia Pacific region, including Pakistan, and I mentioned Asia Pacific because we cannot single out Pakistan for not being up there. They are not on track to meet the WHO HCV elimination goals by 2030. However, significant progress has been made, and this is the redeeming factor, that the liver assessments have been simplified, treatments have been highly simplified, and the care pathways have been made easier. So what we really need is, and we have evidence and we have tools to interfere or intervene in all of these cascade of care things. For example, we have got excellent point of care tests that can screen large number of people in a small amount of time. We have the HCV RNA confirmation mechanisms. Remember that the PCR capacity increased God knows how many fold with the COVID situation. We were doing, only our lab was doing about 3,500 PCRs every day for COVID. Imagine if those could be used for the HCV testing, we could be testing a lot of people. Linkage to care we've talked about, and that could be managed through telemedicine remotely, involving many other people. So effectively, what we need to do is to get that political drive. We have the effective tools, and if these come together, there will be elimination, inshallah, sooner or later. Thank you very much for your attention.
Yes, thank you very much, Professor Said Hamid, for your wonderful talk. And I agree with you that without political drive, the dream of HCV elimination from this country, it will remain a dream. And COVID, with COVID pandemic, it has thrown HCV elimination back by many, many years. So we proceed to the next talk, and next talk is from Professor Altaf Alam from Lahore, a great friend and a great professional. And his talk will be on NAFLD, predicting risk of liver and cardiovascular disease. Is Professor Altaf Alam online?
Yes, sir. Online.
Assalamu alaikum. Can everyone hear me, please?
Yes, we can hear you.
Thank you very much. I will share my screen now. Can you see my slides?
Yes, we can see.
Thank you very much. It is indeed a matter of great honor for me to be invited to talk on this important topic at this prestigious meeting. And I thank the organizers, particularly Brigadier Masood Siddique, for providing me this opportunity. I have no disclosures to make regarding this presentation, and I bring greetings from my hometown to all the people attending this Congress. Now I will begin with actually asking a question. Is the title of talk allocated to me, that is predicting risk of liver and cardiovascular disease in NAFLD, relevant to medical practice? Well, let's look at that. The answer is here. If you look at the mortality risk associated with no NAFLD, NAFLD, and NASH, you can see when you move from no NAFLD to NAFLD, the risk of dying from liver disease increases slightly, but the risk of dying from cardiovascular disease multiplies many-fold. And when you move from NAFLD to NASH, the risk of dying from liver disease also balloons up. And so many patients die from liver disease, and equally large number, if not more, die from cardiovascular disease. Also look at non-cardiac, non-cardiovascular causes, which also increase significantly when you move from no NAFLD to NAFLD and NASH, respectively. As you can see, the risk of dying from CKD, respiratory illnesses, malignancies, both hepatic and extrahepatic, increases tremendously. So yes, the topic allocated to me, fortunately, is very relevant to medical practice. I'll split this talk into two portions. First, predicting risk of liver disease in NAFLD, and second, predicting risk of cardiovascular disease in NAFLD. So first, predicting risk of liver disease in NAFLD. You know very well that normal liver to NAFL, where there is fat in the liver, but no inflammation, no fibrosis, these are easy, relatively easy to handle. You can follow these patients up, provide them non-pharmacological management, particularly weight loss, and they would be followed up in your clinic maybe 6 to 12 monthly. But when you move to NASH and cirrhosis, the risks of dying from liver, cardiovascular, and other causes increases significantly. And this is what I'm going to talk about. I'm not going to discuss the etiology on this talk of NAFLD, but certain genetic association or genetic polymorphism in PNPLA3, TM6, SF2, GCKR, SOD2, and MBOT7 are strongly associated with liver disease. These polymorphisms in such genes have either neutral or inverse relationship with dying from cardiovascular disease. So one needs to remember the association of genetic polymorphism with cardiovascular and hepatic mortality. Also of importance are epigenetics, where the genes do not show any polymorphism, but the expression of genes is altered by some environmental factor, which in the context of NAFLD is gut microbiome. The dysbiosis, the increased or altered intestinal permeability, and the mediators which regulate the gut microbiota induce some changes in gene expression, which can lead to risk of NAFLD, and this is strongly associated with mortality from cardiovascular disease in NAFLD, as well as hepatic disease in NAFLD, unlike genetic association. So the $1 million question is, if you have 100 patients in NAFLD, how many have NASH and how many have advanced fibrosis? And these are the two key factors which impact the future outcome and eventual mortality. So in this presentation, I'm going to talk about how to identify patients with NASH and also those with increased fibrosis. Fortunately, if we have 25% prevalence of NAFLD in a population, only about 3 to 5% have NASH and only 1 to 3% have advanced fibrosis. But look at this chart. The higher the fibrosis, the higher the risk of dying if you follow them up over 1 to 4 decades. So minimal fibrosis or no fibrosis, the risk of dying is just the same as general population. But as the fibrosis increases to F2, F3, and F4, the risk of dying over the years increases proportionately. So this is the $1 million question, how to identify NASH and higher degrees of fibrosis and cirrhosis in patients with NAFLD. The clinical predictors of NASH in patients with NAFLD are given here. They do not make a diagnosis, but they should alarm you that advanced age, male sex or postmenopausal women, certain races like Hispanics in US and Asian patients, those with metabolic syndrome, persistently high enzymes, particularly reversal of AST and ALT ratio, low platelets, and persistently elevated ALT are associated with NASH, and one should specifically keep them under surveillance and do more for such patients because they may have NASH, which will eventually progress to fibrosis and cirrhosis. Now, you know very well that we use various tools for the diagnosis of NAFLD, but as you can see here, liver enzymes are not very sensitive and specific. You may have normal liver enzymes in NASH, so they are not very sensitive and specific. And with low degrees of fat in the liver, ultrasound is not very sensitive. CT is similarly less sensitive but more specific. MRI, again, if you use proton density for fat fraction mode, it has high specificity but lowish sensitivity. And the best tool is MRS or MR elastography, which equates almost with liver biopsy in the diagnosis of NAFLD and NASH. Liver biopsy is considered to be the gold standard, but there are many problems with this, as we will see later on. So liver enzymes, ALT, AST, not sensitive for NAFLD or NASH. Non-invasive tests, well, there are many. I'm only going to put emphasis on APRI, FIB4, and NFS, NAFLD fibrosis score, because they are easier to do and do not require specialized tests. I'm not going to talk about FibroSure, ELF, HEPA score, etc., because again, the parameters that are needed for these tests are not commercially available in Pakistan and maybe in many countries around the world. FibroScan, I will certainly going to talk about it. MR elastography is not freely available, is expensive, and RFI has never found itself a place in the diagnosis of NASH and advanced fibrosis. Similarly, NIS4, Fibroscapt, Adapt Pro C3, and cytokeratin 18, I'm not going to talk about them because these tests are not commercially available in Pakistan. But something new, FAST, which incorporates AST, FibroScan, and CAP, controlled attenuation parameters, which most of the machines now have this software, and you can determine the fat in the liver. A combination of these tests by means of a app available on your smartphone has found to have some useful place in predicting fibrosis, steatosis, and inflammation in people with NAFLD. So remember this, FAST score can be easily calculated if you have CAP and FibroScan values with you. AST is always there. So proper use of non-invasive tests can aid, if not in diagnosing higher grade of fibrosis, at least excluding them. And I will just highlight that it is so easy. You have these calculators in your smartphone. You can easily calculate NAFLD fibrosis score and FIB4 scores, and they can help you in stratifying your patients, whether they have higher degrees of fibrosis or no fibrosis. They certainly, as I mentioned, help in excluding absence of advanced fibrosis, and in clear-cut cases, make a diagnosis of advanced fibrosis if the scores are high. But they are hampered by a lot of indeterminate cases, which you see with the use of such scoring systems. FibroScan is useful in ruling out advanced fibrosis, so it has a high negative predictive value. And if you have a score of less than 6 to 7, it is highly unlikely that your patient has advanced fibrosis. And you keep them as low risk and just follow them up and provide them general advice. Higher values increase the likelihood of more severe fibrosis, and which predicts the risk of decompensation and other complications associated with it. You must remember that overestimation of fibrosis can occur in hepatitis, if there is raised ALT due to any cause, cholestasis, liver congestion, particularly in heart failure, and in obesity, you have to use the right uh, probe to get the meaningful values. If the fibroscan values are 20 plus, it correlates very well with portal pressure, and it is used along with low platelets to screen patients for varices on endoscopy. Just to highlight that CAP is helpful. These are the cutoff values, and many of my patients are certainly motivated by seeing S3 values, which means more than 66% of liver is replaced by fat, and it gives them the motivation to lose weight and get rid of this fat. So CAP has its value and should not be underestimated in the evaluation of patients with NAFLD. Sequential use of non-invasive tests certainly goes a long way to reduce the number of indeterminate cases. So you use it once, call back your patient in 6 to 12 weeks, do it again, and you will find that it excludes or confirms fibrosis in more number of patients than the initial evaluation. So using all this information, low age, no diabetes, no obesity, low fibroscan values, low AST, low NFS and FIB4 scores indicate low likelihood of NASH and fibrosis. But on the other hand, if you have an elderly or older patient with diabetes, obesity, hypertension, higher KPA values, higher ALT, and higher values of NFS and FIB4, this has a high likelihood of NASH and fibrosis and would benefit from further workup. So it helps to identify patients who have high risk of fibrosis. And this is how we do. After using all this information, we select patients for liver biopsy. And high risk and those patients who are in indeterminate category may be helped by doing a liver biopsy. What does the liver biopsy do? It makes diagnosis of NASH, it stages fibrosis, and rules out any other disease which might have been missed, like autoimmune, Wilson's, DILI, iron overload, etc., in patients whom we are evaluating for NAFLD. The problem with liver biopsy is that it is invasive and painful, expensive, associated with morbidity and mortality, with sampling variability, inter-observer variability. You need expertise to perform, and is impractical for population screening. Is a liver biopsy always necessary in NAFLD? Certainly not. It is not required if you can exclude higher degrees of fibrosis and stage disease and stratify risk progression by other means. It should be tailored to the individual patient where there are marked biochemical abnormalities on LFTs, diagnosis is in doubt, non-invasive scores that are high or indeterminate, and if the patient is willing to have it. So it has a role. I'll end the evaluation of liver disease predicting mortality by incorporating endohepatology as a one-stop solution for evaluation of patients with NAFLD. If you are a follower of Kenneth Chang from US, you will certainly know that in one session, you can screen for varices by doing EUS. You can do the shear wave elastography. You can obtain a good liver biopsy specimen using Francine or fork tip, whatever needle is available. And you can directly measure portal pressure and hepatic vein pressure and hence calculate HPPG. This is particularly useful in difficult patients with multiple comorbids who are being evaluated for some invasive procedure or surgery. and it will guide you and stratify the risk of surgery and whether the patient can undergo such difficult procedures or not. So something which will make its place more and more in the future, but certainly worth knowing that these are the steps whereby you can select which patients from NAFLD cohort have NASH and advanced fibrosis, and you can keep them surveillance. Now, moving gear and predicting risk of cardiovascular disease in NAFLD. Is it important? Again, yes. The same slide that I showed you earlier, the risk of dying from cardiovascular disease balloons up as you move from no NAFLD to NAFLD. So it is important to stratify your patients with some means about the risk of cardiovascular disease. And both EASL and ASLD guidelines highlight that you should screen for cardiovascular disease and you should stratify risk of cardiovascular disease in patients with NAFLD. There is a lot of literature in support of risk assessment for cardiovascular disease in NAFLD and need to screen for it. I will not go into the details, but you can go through this, browse through the literature, and you will find there is sufficient data in literature to support this practice. What is the spectrum of cardiovascular disease in NAFLD? Well, almost everything can happen. Arrhythmias, valvular heart disease, autonomic dysfunction, cardiomyopathy, atherosclerotic cardiovascular disease, and cholecardia. I don't have time to talk about it, but certainly something which is coming up of interest for both hepatologists and cardiologists. What do I do? In my patients with NAFLD, I use one of these scoring systems, particularly ACC, AHA, cardiovascular risk stratifying score. All these systems use gender, age, cholesterol, HDL, blood pressure, whether on medication for blood pressure, smoking, diabetes, known cardiovascular disease, family history of cardiovascular disease, and Reynolds risk assessment also incorporates CRP, which in my opinion is important in terms of NAFLD. In future, you will see the addition of NAFLD and its scoring systems to these screening tools for cardiovascular disease because it is important. So I use ACC scoring system for my patients with NAFLD. If I find a high score, I refer them to cardiologist. If they have low risk, I just follow them up. But for indeterminate or intermediate risk, I do recommend that if you have this coronary artery calcium scoring available, your CT, if this has the software to calculate coronary artery calcium score, it would be helpful. If you don't have it, you can rely on your risk scoring and start anti-hyperlipidemic treatment and refer high-risk patients to your cardiologist. If you calculate high calcium score on coronary artery calcium scoring on CT, you can pick up intermediate and high-risk patients to go to your cardiologist for further screening. So what do you do if risk of cardiovascular disease is moderate to high on stratification? I refer my patients with NAFLD with moderate or high risk of cardiovascular disease to cardiologist for further assessment and intervention. So in summary, Mr. Chairman, ladies and gentlemen, NAFLD and NASH is associated with high risk of liver-related morbidity and mortality. And it is also unfortunately associated with high risk of cardiovascular disease and cardiovascular disease-related death. It is important to recognize those at risk of hepatic and cardiovascular events to intervene early. In NAFLD patient at risk of liver-related mortality, assessment for NASH and fibrosis is the key. And those at risk of cardiovascular disease, use of simple risk stratifying scores and tests may facilitate early referral to cardiologist for intervention. And please don't forget other associated risk factors in NAFLD. The biggest balloon leading to mortality is non-hepatic, not cardiovascular. So don't forget about that and be mindful of those malignancies which can occur in such patients, and also of cerebrovascular disease, CKD, pulmonary diseases, etc., which happen in these patients. So that's all from me. Thank you very much. And I wish you all a very, very happy ending to this wonderful meeting. Thank you very much.
Thank you very much, Professor Altaf Alam, for your wonderful talk. And as always, you made it very, very simple for your audience, and you sent your message across, which is very, very clear. Thank you very much indeed.
Before we call the next speaker, I see amongst the audience, Dr. Mashood has come back. Dr. Mashood, you are supposed to be a chair, so please, if you can take a chair, and Dr. Mashood, sir. Our next speaker is going to be Dr. Saad Ali Khan, and he's going to talk about cholestatic liver disease, PBC and PSC.
Okay, I'll start with a real case scenario, which we managed last year in our hospital. So it's basically about two diseases I'll be talking about very, very briefly. And the first one is PSC. So a young female, 37 years of age, who had ulcerative colitis for last 7 years, which was quite well controlled, presented to our hospital in PEMH, Rawalpindi, last May. And she presented with fever, yellow discoloration of eyes. Her ulcerative colitis was quite well controlled. She was spiking temperature, 101, 102, associated with rigors and chills. She had progressively worsening jaundice and generalized body itching. If we go back a little bit, a month before she came to us, she was admitted in one of the hospitals in Jeddah, Kingdom of Saudi Arabia, where once she was scanned, she was found to have two dominant strictures. So she had ulcerative colitis, she had PSC, and they found that she had two dominant strictures, one in the left biliary system and one in the common hepatic duct. They tried to negotiate it through ERCP, but the strictures were too tight to negotiate through. Considering that she had recurrent episodes of cholangitis, she was asked to undergo liver transplantation, and she was being assessed for that. Her brother was, the whole family was from Pakistan, so they thought of getting a second opinion from Pakistan, and they came to us. Just briefly, regarding her past history, ulcerative colitis was well controlled. She was on mesalamine and azathioprine, which was started after she had 3 flares in the past. Nothing significant in personal or family history. Same goes for the travel and socioeconomic. These are the drugs she was on. So once we examined her, she was tachycardic, was spiking temperature, she was jaundiced. On examination, she had 2 drains in place. One was the PTBD, which was in the left hepatic system, and the other one was free peritoneal drain on the right side. Nothing to mention about in central nervous, cardiovascular, or respiratory system. So she got admitted with us. We sent blood samples for labs. It turned out she is anemic. Her full liver disease screen was negative. So this is her liver profile. Her bilirubin was quite high, and same was her alkaline phosphatase. Her ultrasound abdomen did not show much except for mild dilatation of the biliary tree, intrahepatic biliary tree. The extrahepatic biliary tree was all fine, looked all fine on ultrasound. Her fibroscan reading was slightly high, which we believe was because of bile stasis. No varices on endoscopy. So if I could just explain what the people in Jeddah found on MRCP. So she had one dominant stricture over here, which is the left biliary tree, just prior to the confluence. And this could not be negotiated through PTBD because after they could not do ERCP, they went for PTBD, but they could just place the drain up to here. And this stricture could not even be negotiated through PTBD. And then one stricture, dominant stricture, was down there in the common hepatic duct. And this was earlier attempted with ERCP over there and could not be negotiated through. So now she had two strictures and a drain which was up to this point in the left biliary system and one drain in the peritoneal cavity on the right side. We wondered if we should go for another ERCP. My opinion was that in such cases, we need to treat her cholangitis first, so she should better go for PTBD, and that should be done. These strictures should be negotiated through PTBD, because certainly this would not have been an easy or straightforward ERCP. So we asked our IR team, they did this cholangiogram. This is the right biliary system. This is the left biliary system. The confluence, external drain on the right side, which was in the peritoneal cavity. And then this is the PTBD drain. So now this was all done over here. They tried to put this drain into the left system and they tried to negotiate through this first dominant stricture, which was in the left biliary system. So if you see that this left biliary system is this all looks like to be beaded with many strictures. And this gave us a picture that this dominant stricture has probably caused secondary sclerosing cholangitis over here, and this is all damaged because of that. So our IR team took the guide wire from the left system through the stricture, which was in the left biliary system, and they balloon dilated it. However, they found it again very challenging to go down through the common hepatic duct stricture. So they just took the drain from the left into the right system, at least to treat her ongoing cholangitis. And then she came, and then we thought that might as well go for ERCP. Let's see if we can negotiate the stricture of common hepatic duct. The contrast was not going up, it was all trapped below the stricture. Luckily, we got the wire through the stricture into the right system. And then we did dilatation with Sohindra dilator. And ultimately, we could place in an 8.5 French stent through the stricture. And this went right up to the confluence. And now we wanted to assess if this stent is really going to function and if we could take this external drain out, because this stricture had been balloon dilated. We were not concerned about that. We were only concerned about the stricture in the common hepatic duct where this stent was placed. We placed 8.5 French stents, so we wondered if it's going to function or not. We asked our IR team if they could do a cholangiogram. So this is the cholangiogram at baseline. The contrast entering from here went all into the right system. They clamped this after pushing the contrast in. After 5 minutes, the contrast from the right system started draining down through the stent. After another 12 minutes, that is total of 17 minutes, nearly all the contrast had washed out through the drain. So then that made us believe that the stent which was placed through ERCP is functional. Now, if we look at the readings here, at baseline, in last year, May, when she presented in Jeddah, her bilirubin was 257. It came down to 206 when PTBD drain was placed proximal to the stricture in the left biliary system. And then when PTBD was done here, when they negotiated through the stricture of left biliary system, it came further down to 150. After ERCP, it came down to 73 when the second stricture was also negotiated through. After removal of PTBD drain and few days after the stent was placed, and later on we upsized that with the 10 French stent, and this was her final reading. And about 6 weeks ago, we asked, the lady has gone back to Jeddah, and we asked if she could send the latest labs, and her bilirubin had come down to 16 then. Sorry. So this 257 came down to 16 over 6 to 7 months time. And similarly, the alkaline phosphatase came down as well. So it's been more than 8 months now, and she has not had requirement for any assessment regarding liver transplantation. So it was about basically the dominant stricture, which was treated through both balloon dilatation and placement of the stent. So if we could just talk briefly about which one is superior regarding stent placement or the balloon dilatation for the dominant stricture. So this is one of the systemic reviews which was done last year and meta-analysis. According to this meta-analysis and systemic review, balloon dilatation and stent placement for dominant stricture, they both show similar results. However, the stent placement is more of a risk for potential complications, in particular cholangitis. So let's see how this lady progresses now, because she has been balloon dilated and has stent in situ as well. So this is just about PSC in my talk. And now very, very briefly about primary biliary cholangitis. We suspect primary biliary cholangitis when we find that the alkaline phosphatase levels are high, whether the lady has got typical signs or symptoms of PBC or not. In that case, we do scans like either ultrasound or, if required, MRCP to exclude any extrahepatic biliary obstruction. And then we check the anti-mitochondrial antibodies. There are certain situations we come across. So what to do when alkaline phosphatase is high, anti-mitochondrial antibodies are positive with a titer of at least 1:40, and the clinical picture is suggestive of PBC. Suggestive means middle-aged lady with no other ongoing liver disease. In that case, we won't go for liver biopsy, and we will assume and treat it as PBC. So what to do when we find raised alkaline phosphatase and raised and positive AMA, but the picture is not suggestive? Could be male, could be of like maybe having conditions suggestive of NASH, like diabetic, obese. In that case, we can go for liver biopsy to confirm and stage the disease. Regarding raised ALK phos and negative AMA, again here we will consider doing the liver biopsy. Normal ALK phos, positive AMA with high suspicion like middle-aged lady, we may not go for liver biopsy. And if in doubt, then we consider liver biopsy. If both are not indicative of PBC, normal ALK phos, negative AMA, we have like sort of excluded PBC in this situation, and we need to consider other causes of deranged liver profile. PBC has changed a bit in last 3 decades. So this is a study which was conducted. It was an observational retrospective study which was conducted over a period of many decades. So they took 3 cohorts in this study. One was they recruited patients of PBC who were diagnosed with PBC from 1982 till 1999. Second cohort was from 2000 to 2010, and the last cohort was from 2011 to 2016. There were around 508 patients, and it was found that compared to the patients who were diagnosed in the first cohort, like before 1999, the male to female ratio was quite different. So it was 1:16. And when they compared it with the last cohort, which is from 2011 to 2016, the male to female ratio was 1:4. So from 1:16, where with female predominance, it went to 1:4. So this is how there has been an increase in male to female ratio. Similarly, regarding the age of diagnosis, there has been an incremental rise in the age of women who were diagnosed with PBC. So initially, the average age was 54 years, and subsequently they found that the average age now is 60 years. There has been good response to ursodeoxycholic acid. They said they concluded that nearly 30% of the patients responded to ursodeoxycholic acid in the first cohort, and nearly 70% have responded as per the Barcelona criteria in the last cohort, which is from 2011 to 2016. And similarly, they found better survival. So overall, they concluded that this better response and longer survival is most likely because of the early diagnosis of this disease. Now, the question is what to do when our patients do not respond to the standard doses of ursodeoxycholic acid. There has been a debate whether to increase the dose or not. So there was a study which was published this year in one of the journals of Germany, where they said that this is that study. So they took 2 cohorts, 73 patients who did not respond as per the Paris 2 and Barcelona clinic criteria. 73 patients did not achieve remission, or we can say did not respond to the standard dose of ursodeoxycholic acid. They divided those 73 patients into 2 cohorts. First was continued to be on a standard dose, and the second one was given high dose, which was 18 to 22 milligram per kg body weight. Over a period of 12 months, they found a significant difference in the 2 groups. The first cohort, which was continued to be given the standard dose, in that case, the response rate was 47%. And in the second group, where the dose was increased, the response was nearly 60%. So it was suggested that before going on to the second line drugs, there is an option that we could increase the dose to 18 to 20 milligram per kg body weight of ursodeoxycholic acid. Now the last point here, what are the extrapyramidal signs or symptoms in patients who have cholestatic liver diseases? Manganese and copper are mainly excreted through liver and the biliary tree. But what happens during cholestasis is that they get accumulated and get deposited in the basal ganglia, leading to extrapyramidal signs in the patient. Now, if we have a look at this study, which was published in the Scandinavian Journal, and this was from 2021, the aim was to see the effect of cholestasis on manganese and copper levels in the blood of patients with PBC and PSC. So there were 3 cohorts those 20 patients of PBC, patients of PSC, and the control group. Patients who had PBC or PSC, they did not have significant difference in their blood levels of manganese and copper, but patients who combined these two groups, they certainly had significant difference in manganese and copper levels compared to the controls. So in this group, in these two group of patients, the manganese and copper levels were certainly high. So what they found was that if patients are treated with ursodeoxycholic acid or they undergo liver transplantation and we remove this problem of cholestasis, then lab cholestasis markers get normalized, the levels they come down, and patients are protected against these extrapyramidal signs. Therefore, we need to not only monitor cholestasis, we need to look for liver functions, magnesium and copper levels, and also to look for extrapyramidal symptoms in patients who have cholestatic liver disease. So I'll end here and happy to take any questions. Thank you.
Dr. Rawzat Ali Khan. And our next speaker is Dr. Amna Subhan from Karachi, and her topic is acute liver failure and its management.
All right. So thank you very much. So I just want to confirm, am I audible and are my slides visible to everyone?
Yes, for both. Thank you.
Thank you very much. So first of all, I would like to thank Professor
Dr. Amna, can you hear us?
Yes, I can hear. Let
Dr.
me
Amna,
do.
can you hear us?
Yes, yes, I do hear you all. Do you hear me now? Am I audible?
Yes, you are audible now.
All right. Thank you very much. So, Assalamu alaikum, everyone. Good afternoon. So, I would like to thank Professor Masood Siddiq and the scientific committee of PSG for giving me this opportunity to speak on this forum. So for next couple of minutes, I'll be talking about the management of acute liver failure, which itself is a huge topic, but I'll try to sum up the salient point. So I don't have anything to declare as a conflict of interest. So here is a case of 48 years old woman who presented to emergency with altered mental status over the last several hours. She was found by her husband earlier in a day to be acutely disoriented and increasingly somnolent. 2 days back, she has reported some symptoms like fatigue and nausea. And on examination, she was found ecteric, extractors were present, she was tender in right hypochondrium, and she was having grade 2 hepatic encephalopathy. So the initial labs which were sent to the emergency department revealed high transaminases, particularly ALT, high total bilirubin, and a high INR. So now the question for whenever you see such type of patient, and we do all see such patients in our routine practices. So the first question comes in our mind, that is this acute liver failure, or this is an acute hepatic decompensation, or this is an acute on chronic liver failure. So as we all know that acute liver failure is a rapid decline in hepatic function, which is actually characterized by the derangement in liver functions, manifested clinically by jaundice, and biochemically by elevation in enzymes, as well as the coagulopathy, which experience over the period of like 12 weeks or less than 2 weeks, associated with the presence of altered mental status in a form of hepatic encephalopathy. And these are the all parameters we actually use to define acute liver failure. So when the patient comes to you, always look for these things, and especially the presence of any underlying disease which is known or not known. However, there is an exception, which is the patients with chronic autoimmune hepatitis, Wilson and Budd-Chiari syndrome, which could be considered as a case of acute liver failure. If they develop hepatic encephalopathy despite the presence of pre-existing liver disease, which was pretty stable or was not diagnosed in context to the appropriate abnormality in the liver function test and the coagulation profile, as I've mentioned before. So it is classified based upon the duration from the onset of jaundice to encephalopathy as an hyperacute. If it is actually manifesting within 7 days, as an acute one, if this is actually manifesting from the day 8 to day 28, or from the start of the second week up to the week 4, or a subacute one if it is actually ranging from 29 days to 12 days. So the term acute liver failure is preferred over the term fulminant hepatic failure, and this is how we use. And this classification, which is usually now followed, this is called as an O'Grady classification of acute liver failure. So is there any difference in their clinical manifestations? To answer is a little yes, there is some difference when they present, and this will actually help you to have some idea about the further course of the disease in the near future. For example, in case of hyperacute acute liver failure, these patients usually have more severe coagulopathy, and the degree of intracranial hypertension is like more marked over here. The chances of recovery, spontaneous recovery, are better in these cases, and most of such cases are because of either paracetamol-induced toxicity or viral hepatitis like hepatitis A and E. In case of acute liver failure, they have like coagulopathy, which is definitely severe, but less severe as compared to a hyperacute one. The jaundice is more marked. The degree of intracranial hypertension is also more marked, but these chances of spontaneous recovery is like moderate. In such cases, for examples, are because of chronic conditions like chronic hepatitis B, sometimes because of autoimmune hepatitis and all. In case of subacute one, the severity of coagulopathy is less, jaundice is more severe, intracranial hypertension may or may not be that marked, but the chances of spontaneous recovery is poor, and these cases is mostly because of non-paracetamol drug-induced injuries, and it includes many other causes. So whenever a patient is presenting to you, how can you assess them clinically and then laboratory wise? So always try to have some idea about that. What was when the jaundice was like observed or established? Try to identify the changes in their mental status, for example, the duration of confusion, slurring of speech, agitation, so that you can have an idea about that, which degree of encephalopathy the patient is having. Explore about the constitutional symptoms coexisting. Medication history is again very important. For example, sometimes the patients are actually taking over-the-counter medications, and the medications being used, for example, somebody was having a fever, and this was because of a viral cause, but for fever, somebody has used paracetamol, and this cumulative paracetamol dose might be significant one. So the medication history in terms of toxicology, as well as like concomitant hepatic injury, is important. The history of travel and the previous history of seizure, developmental delay, liver diseases, these are the things that actually can give you a clue about the etiology. The family history is again important. The physical findings is actually suggest that whether there is an underlying, are there any stigmata of underlying chronic liver disease is present or not, because definitely this thing is actually also help you to have some idea about the course of the disease as well as the prognosis, and based upon that you can channelize your treatment for that particular patient. So we all know that these are the different etiologies which can actually lead to acute liver failure. So the distribution of these etiologies is actually different in the different areas of the world. For example, in the less developed countries, like for example in Asia, viral hepatitis is like considered as among the most common etiologies, especially hepatitis E in adults and hepatitis A in children. On the other hand, for example, the country China and Japan, hepatitis B is a predominant cause. And on the other hand, in the Western population, paracetamol-induced acute liver failure, as well as alcohol-related acute liver failure is more predominant as compared to viral causes. So when you are assessing the patients clinically, again, you can get some idea from their presentation. And why I'm emphasizing again and again, because then you can actually start or consider the cause specific treatment while you are managing these patients. So in case of paracetamol related acute liver failure, these are the patients who have usually very high aminotransferase levels and relatively lower level of bilirubin, rapidly progressive disease, acidosis, and renal impairment right from the beginning. They do have, if this is a severe paracetamol-induced liver injury. Low phosphate may be seen as a good prognostic marker, but definitely the replacements will be needed. In case of non-paracetamol-induced cases, subacute clinical course can mimic like the cirrhosis, especially when you do the radiological examination, and sometimes they also have ascites. In case of acute Budd-Chiari syndrome, abdominal pain, ascites, hepatomegaly, loss of hepatic venous signals, and reverse flow in the portal vein on an ultrasound, these are the main features where you can suspect it. And again, the time of presentation. For example, a pregnant lady presenting with ascites during a pregnancy, think about this cause. So in case of Wilson's disease, usually the patients are young and they may have a concomitant, for example, hemolysis. So if young patients are presenting with the neurological signs, hepatitis, hemolytic anemia, think about it. Mushroom poisoning, severe gastrointestinal symptoms after ingestion and development of early AKI. In case of autoimmune hepatitis, usually they have subacute presentations, and usually the patient may have some concomitant symptoms, maybe a history of joint pains, skin rash, and all. In case of malignant infiltration, definitely, but the picture will be a little different. Again, this type of demarcation, while the patient is presenting and trying to get some idea about an etiology, will also not only help you to have an idea about the disease course and the specific treatment for that disease, but also will give you some idea about the liver transplantation as well. For example, the patients with all of these categories, they could be considered as a better candidate for liver transplantation as compared to those who will be presenting with malignant infiltration. So remember, when you are assessing this patient, on each and every step, you will be assessing them in terms of current management, their further disease course in the future, possible treatment you can provide them, prognosis, and the possibility of their candidacy as a liver transplant candidate. Because definitely the disease rapidly progress, you won't have much time. So you need to actually think, assess, and plan accordingly very quickly. So make sure that your patient is being cared at a proper setting. For example, if the patient is having grade 3 or 4 encephalopathy, should be going to an ICU. Ideally, all patients should be in ICU, but definitely ICU beds are limited. So patients with grade 1 or grade 2 encephalopathy, they can be managed in high dependency unit. For example, the hospital facilities where the special care units are available, they can be treated over there. But with keeping this in mind that they may require intubation at any point in time in an ICU care. So when they're presenting, so to assess the disease severity, these are the tests you can do, and the serial monitoring of prognostic factor. For example, the prothrombin time will also be needed. Arterial blood gases and lactate level, they will give you an idea about the further worsening and all. So the test to evaluate for underlying etiology is important. You can customize, or you can tailor the selection of tests based upon your clinical assessment, and definitely sending all of these tests right away may not be cost effective for a country like Pakistan, but definitely based upon a good history, you can send them the common etiological factor or a specific test, for example, in autoimmune hepatitis or Wilson's, if there are some clinical clue. So the test for the complications, for example, the amylase lipase, as well as X-ray chest and ECG, if needed, these things could be done. Try to evaluate them for a presence of underlying cirrhosis, which may not be identified earlier. In certain cases where there will be the liver biopsy will be needed, but definitely these are the selective cases. For example, when you are suspecting an autoimmune hepatitis or a Wilson's disease, something like that. So whenever you think that there is a need for liver biopsy, the transjugular liver biopsy is considered better as compared to transabdominal liver biopsy. So as I said, that associated test, for example, to identify whether there is an ongoing infection in a chest or not, ECG could be done. So monitor them, their vitals, urine output, neurological status, avoid sedative, take care of their hypoglycemia issues and all. So these are the potential complications of acute liver failure these patients develop. For example, the hemodynamic instability, they're prone for arrhythmias, they're prone for infection, especially the bacterial and fungal infection. So the coagulation disorder and hemostasis disorders are quite common. They do develop the pulmonary complications, acute respiratory distress syndrome, and fluid overload. The CNS the CNS complication for cerebral edema manifested in a form of encephalopathy, metabolic derangement, and the renal function. These are the potential organ-related complication these patients can manifest. So how about hemodynamic management? So these patients, due to low systemic vascular resistance, and sometimes they are intravascular volume depleted, they do have hemodynamic instability. So you can resuscitate them with the help of crystalloids like normal saline. If they are acidotic, then you can combine half saline with sodium bicarbonate. If they're getting hypoglycemic, then the dextrose should be added to the crystalloid solution if the patient is having hypoglycemia. And if somebody is having a persistent hypoglycemia, then you can add 10% dextrose as well. So if the patient require vasopressor support, so then you can use norepinephrine, which is considered better. But if patient is not responding to that, then you can add vasopressin. And if someone is actually having a persistent hypotension, you remember these patients are prone for hypoadrenal insufficiency. Here you can give them a trial of steroid. So hyperkalemia, hyponatremia, hypophosphatemia, potassium electrolyte imbalances, all of these metabolic abnormalities these patients are prone for. So you need to check them periodically and correct them if they are present. Lactate elevation is related to increased production and decreased clearance, and it remains a poor prognostic marker. And if there is severe lactic acidosis, then RRT is indicated to correct acidosis and other metabolic disturbance. So the coagulation disturbance is pretty common, but the prophylactic administration of FFP is not recommended because it doesn't have any influence on mortality. It can interfere with the assessment of liver function and may lead to fluid overload. So if somebody is anemic, then the target hemoglobin is like around 7. If less than that, then you can transfuse them. And as they are coagulopathic, and the most common site for these patients are GI tract, stress-induced ulcers, and precipitated by the coagulopathy. So the prophylaxis with PPI or H2 receptor blocker could be provided to these patients. So the infections, the risk of infection is quite high. So the most common site of infections are respiratory tract infection, UTI, septicemia, and remember that they have the tendency for the fungal infections. So the suspicion for fungal infection should be low, and early identification always helps the patient. So remember that many times the localizing signs of infection, for example, fever, sputum production, these are absent, and the only clue for the ongoing infection is maybe the worsening of encephalopathy or renal function or an overall deterioration. So the prophylactic, so the culture should be done for such patients, especially if they are deteriorating. So the role of prophylactic antibiotic is controversial, and most of the authorities suggested that give antibiotic broader spectrum if there is an evidence of ongoing infection, positive surveillance culture results, or clinical deterioration. Hepatic encephalopathy is a major problem for such patients, and this could be managed with the help of medication. We have to clear ammonia, including rifaximin, lactulose, and all. And some supportive treatment is also needed for such patient. For example, the surrounding should be quiet. You can elevate the head, and the role of hypothermia is plus minus. And again, if the patient is progressing to grade 3 or more than that, then better to intubate them, ventilate, and sedate if they have grade 3 or grade 4 encephalopathy. And this is to protect the airway, prevent an aspiration, and provide a safe respiratory care. So definitely the target PCO2 levels are defined. If you need to sedate them, you can use propofol. And in case of seizures activity, monitoring with EEG and relatively better, less hepatotoxic anti-epileptic drugs could be added if needed. So the nutrition is a vital component, and this is one aspect often we ignore. This is a high catabolic condition, and here the patient require high calorie diet, and so that the calorie count could be maintained. And this is also required to prevent catabolism of body stores of protein, because if you'll be providing low caloric diet, the body will be using proteins and the fats, and that will be a problem for the patient. A daily intake of 60 gram of protein is reasonable. Oral, if this is grade 1 encephalopathy, diet could be given, or antral feeding could be given. Placement of NG tube can increase an IC, raise intracranial pressure because of gagging, and should generally be performed only in patients who are intubated or sedated. If adequate antral feeding cannot be provided, then the parenteral nutrition could be provided to them. Invasive airway management is required in the phase of progression of high grade hepatic encephalopathy, grade 3 to 4. And many of them, they do have acute kidney injury and metabolic acidosis. And here you can provide them RRT. Remember, the medication to be avoided, including hepatotoxic drug like paracetamol and others. Sedation ideally should be avoided. But if you need to give them, for example, the patient is very, very agitated, then the short-acting benzodiazepine could be given. If you need to sedate them, for example, on the ventilator, then propofol can be given. And these are the preferable medication over opioid. The next come to the specific treatment of an underlying cause. So we all know that if somebody is having an acetaminophen toxicity, N-acetylcysteine is the drug which improves the prognosis, and the threshold to give it is actually should be low, especially not only in patients who are having acetaminophen induced toxicity, but now it's recommended that the patient who haven't used the toxic dose, relatively lower doses, it may be toxic dose for that person. For example, somebody is using alcohol on a regular basis, relatively lower dose could be a toxic one. So by giving a benefit of doubt, you can give an acetylcysteine to the patient even on the lower dose. So what about those patients who doesn't have any history of acetaminophen induced toxicity? Though the data is limited, but it's still there is an evidence available that it is reasonable to give it to the patient who are not candidate for liver transplantation, and to the patient in whom acetaminophen toxicity may be contributed to the liver failure, even if the lower doses received by the patient. So there was a placebo-controlled trial involving 173 patients with ALF due to the causes other than acetaminophen, and it included the patients who have drug-induced liver injury other than acetaminophen, autoimmune hepatitis, hepatitis B, and other causes. And here, the acetaminophen, N-acetylcysteine was given in a form of infusion, which showed some good difference in transplant-free survival in between the two groups. And you remember the largest trial, which was done by Professor William Lee, ALF group in USA, and there they have used it in patients without acetaminophen-induced toxicity and found was reported to be having a beneficial effect. So for hepatitis B, the role of antiviral therapy, it could be considered, though it hasn't been proven to have a big impact, but it can actually improve post-transplant outcome in such patients, so it could be considered. So for acute Budd-Chiari syndrome, method to restore hepatic drainage, including TIPS, surgical decompression, or thrombolysis could be considered based upon, depending upon the situation. So in case of autoimmune hepatitis, corticosteroid had not been convincingly shown to improve outcome, but a trial of corticosteroid could be administered to the patient with low-grade hepatic encephalopathy and only but for a time period. But if the patient is not getting better within the 7 days, these patients could be considered for liver transplantation. If there is an evidence herpes simplex infection, acyclovir could be given for patients with Wilson's disease. Typically, they require liver transplantation. There is no good role of chelation therapy. However, the plasma exchange to remove the copper may act as a temporizing measure. The dialysis and all doesn't show any much significant role, though they can actually remove some amount of the copper. So the pregnancy related condition, for example, HELP and acute fatty liver of the pregnancy, prompt delivery can improve your patient outcome. Mushroom poisoning, early administration of activated charcoal is recommended. So the liver transplantation is the modality of the treatment which is actually has shown a revolutionary role in the management of acute liver failure. And 1 year survival following the emergency liver transplantation is now around 80%. The selection is important. It all depends on the accurate prediction of transplant, the prediction of survival without transplantation, and then whether the patient is a good candidate for this or not. So when the patient is actually coming to you right from the beginning, you need to assess if the liver transplantation is not available in your center. It is better to predict that the patient is whether the patient is getting deteriorated and all, and it's better to shift early to the transplant center rather than shifting them late when doing a transplantation for such sick patient may not be an option even in the best center. So the different criterias are actually being used and evaluated. The most famous and widely accepted one is the King's College criteria and the clicky criteria. And these are the differences in the sensitivities and specificities of these different criteria has been used, and still the King's College criteria is like the most widely used one. So what about the role of artificial and bio-artificial liver devices? These are intended to provide a bridge to the transplant or recovery of the liver function, reducing the need for the transplantation. Experience with liver support devices to date has been not that wasn't found that beneficial, but it can be used as a bridge therapy. So, ladies and gentlemen, in summary, acute liver failure has a high mortality. Early recognition and broad investigation for etiologies are required. Timely medical management could actually improve the survival and to avoid the need of liver transplantation. Extrahepatic organ failure is common, and all patients should be discussed with the local critical care team as well as with the regional liver transplant centers. Early shifting to the transplant centers and can help such patients. So thank you very much for your time listening. Thank you very much.
Thank you very much, Dr. Amna, for your wonderful talk. And as in the interest of time, there will be no question answer session as we have to have a closing ceremony as well, and then the lunch will be delayed otherwise. So it's my privilege to thank all the speakers. They all had a great scientific content, great talks, and thank you very much all the audience and delegates for your participation and your patient listening and complying with the COVID SOP. So this ends the session, and we start with the closing ceremony. Thank you very much. May I request Professor Tasawwur Hussain, Professor Amjad Salamat, Professor Farooq Saeed, and Junaid Salim to join here. prize distribution was supposed to be done during the closing ceremony, but as the prize winners, they had to leave for the airport and their flight was earlier, so that has been done. So Core Committee of Federal Chapter Congress 2021 is here, and I would request Professor Farooq Saeed, Chair Organizing Committee, to say a few words, and it will be followed by Professor Tasawwur Hussain and Professor Amjad Salamat and Junaid Salim for their few words.
Bismillahirrahmanirrahim. It's really a great moment that we are seeing the closing uneventful. I will thank all the delegates, all the speakers, and all the participants that they very patiently they observed all the SOPs of COVID, and very diligently they stayed in the sessions and they attended this Congress. I'm grateful to all the speakers, and I'm specifically grateful to Professor Masood Siddiq, who single-handedly did all these arrangements, and we were in fact in the supporting role. So I don't have words to thank him. Thank you very much.
अभी वो कहाँ है रात के?
I'll start again. As Professor Farooq has said, my old friend and class fellow, Professor Masood Siddiq, played the pivotal role in organizing and managing all the affairs in this conference. We have been supporting him all along, and we have tried to do as best as possible. We hope that this conference has been very useful for those who have attended this, and that will really satisfy us if everyone has benefited from this. I'd like to thank all of you for your presence here. It is very encouraging for us to see all of you here and listen to these talks. And thank you very much.
Assalamu alaikum ji. It's a great pleasure and privilege to have all of you here and attend the scientific session. I was a scientific as chairman scientific committee. I hope the scientific program was up to the mark, and all of you enjoyed it. Those who were online and those who were physically present here. We had tried to cover the practical topics and how to manage them practically. I hope it would change your practice or improve your practice. It remains for me to thank Vice President, PSG Federal Chapter, Professor Farooq Saeed, Professor Masood Siddiq for his tireless effort, Professor Tasawwur Hussain, and Dr. Junaid Salim. And I would be amiss if I do not thank my IT team and all the organizers and other individuals who have been involved in this endeavor. I think we must also thank the industry for cooperating with us and the last minute arranging things and supporting us. I would, as I said in my message, if many of you have read it in the brochures and the flyers, I think this conference would not be complete if you do not give us feedback about our faults and follies, so that the next time we can improve that. We have specifically asked for the feedback of postgraduates in this session, in this conference, so that the next time when we arrange that, we can actually select topics of people's interest instead of us dictating it, and that would actually make it more interesting. In the end, I must thank all of you for attending and making it a success. Thank you very much.
Hello. All I would like to add to what has already been said is that Farooq and myself, we were not very much in favor of a physical conference, but Professor Masood Siddiq pushed that we should have a hybrid conference. And to make this possible, we had to be pretty strict, and we stepped on somebody's toes. I'm here to say sorry for the whole organization team, but we tried our best that we should have a safe conference, although we should help people together, but we should have a safe distance and we should not transmit COVID in these circumstances. So we had to be strict inside the hall and at lunch times and dinner times, for which we're sorry. And thank you very much.
अस्सलाम वालेकुम रहमतुल्लाहि वबरकातुहू। मैंने अपने आप को आखिर भी इसलिए रखा है कि मैं आपको सच सच बता सकूं। ये मेरे जितने भी कॉलीग जो बैठे हुए मेरे लेफ्ट साइड पे, ये इनकी मोहब्बत है, ये इनकी फराग दिली है कि इन्होंने जो क्रेडिट के टोकरे भर भर के जो है ना ये मेरे हिस्से में डाल दिए। The fact is that it's a great team. It was a great team effort. और इसमें किसी ने भी कोई कम काम नहीं किया है। जितना काम मैंने किया है उतना ही काम इन सब ने किया हुआ है। तो it was a very good combination. मैं आपको ये बात जरूर बता दूं कि it's not easy to arrange the Congress. Annual meetings होती हैं, it's very difficult to arrange. Preparations start at least a year before. And then meetings and the routine becomes difficult when 6 months are left and last 3 months are critical. Then you are meeting every week. हम एक दूसरे के घरों में मीटिंग करते थे। Every week जो है बारी बारी एक दूसरे के घरों में हम इकट्ठे होते थे और we were making all the arrangements. तो इस सारे प्रोसेस में अगर बहुत सारा क्रेडिट मेरे ज़िम्मे डाल दें तो मेरा ख्याल है ये बात मुनासिब नहीं है, बट आई एम ग्रेटफुल. As I said, that it was a great combination, I tell you. Amjad with his strength of scientific program and a combination of hawks and dove. Should we go for a virtual meeting? We should have a physical meeting. And as the things were moving, the minds were changing, and we were passing through a difficult time. And when 3 days were left to start the meeting, we started hearing about the surge of COVID in the country. And then again, sitting there, should we go ahead or we should not go ahead? And the industry holding their checks with them, that is the meeting is going to be cancelled, our meeting will be there, and there are people asking questions, and then the rumors that the meeting jo hai na wo khatam ho gayi hai. So we have passed through all that, and today this is the closing ceremony, and our team has done a wonderful job. And thank you very much, Professor Farooq Saeed, Professor Amjad Salamat, Professor Tasawwur Hussain, and Junaid Salim for doing a great job. I have to thank the faculty, foreign faculty and the national faculty. And foreign faculty joined us virtually, and the people like David Corlock and Martin Freeman and Professor Limidi, and over international coordinators like Nadeem Tahami and Dr. Wakar. It was all possible with their support, and we really appreciate that, and I'm grateful to all of them. And coming to the support from the industry, I think there's a overwhelming response. There are almost 20 companies, I think. 20 companies have participated. And we were not expecting, to be frank, we were very happy to have 4 or 5 even. And but as the time passed, and they were looking at us, and when they realized that a very serious and a committed team is there, so the response started pouring in. And we are particularly thankful to Firosans, Getz Pharma, Hilton, HiQ, and Wilson Pharma, what they have done for us. And they will be getting shield at the end of the closing ceremony. I must mention about the IT and audiovisual arrangements. It was something very, very difficult to have a hybrid meeting, and speakers in between, they will be joining virtually, and then a speaker will be coming physically. So switching over from one mode to the other mode. And I must appreciate Wilson Pharmaceuticals and their team for doing a wonderful job. I must say the whole meeting has gone problem-free. There were some little bit hiccups, but that is part of the meeting. And particularly Shamsulangi and Dr. Said Firanja, we are very grateful. Thank you very much for your great performance. We are very thankful to all the delegates. The delegates came from all the provinces. And we really appreciate they participated, and probably I can say the participation was not less than any meeting before when the COVID was not around. So, and moreover, that they were following the COVID SOP. We knew that it's very difficult to have mask all the day, but it was something which was required, and we are grateful that you followed it, and you complied with it. It was in the interest of all the delegates and all the people who were here, and we really appreciate it. We are grateful to the hotel management. They supported us a lot, and we have got no complaints against the hotel, and they really played a role in having the smooth Congress. And the core committee sitting here we would like to apologize for any shortcomings which we have noticed in the meeting. We know that we have been blunt in between. We have been stressing upon that please follow the instruction, follow the COVID SOP. And we were very embarrassed and we were very disturbed when we were requesting the people not to bring the families. But it was in the interest of all the audience here. It was in the interest of the Congress that we should not have the families, because we all were scared of this COVID pandemic. So please forgive us for that. If anyone has felt this thing, that we were a bit strict about it, we will certainly like to apologize for that. And thank you very much, everybody. And now we will be presenting shields to Firosans, Getz and Hilton and Wilson Pharma. And to present shield to our platinum sponsor, Firosans, I will ask Mr. Faisal Salim or Mr. Yasir, anyone here? And Professor Amir Ghafoor is going to present the shield. मैं बस announce कर रहा हूँ. Thank you very much. Thank you. And next is our gold sponsor from GETS, Bilal Noor. And this shield will be presented by Professor Tasawwur Hussain. Next is Hilton Pharma, our gold sponsor, and Professor Amjad Salamat is going to present the shield. The final shield will be presented to Wilson Pharma for their audio visual and IT arrangements. And Dr. Said will receive the shield from Professor Zagam Abbas. And thank you very much. And my last words about you have been seeing the girls roaming here, and the boys in the exhibition area and at the entry point. We hired these people to remind you repeatedly to comply with the COVID SOPs. And these young girls, they have done a fantastic job. And we really appreciate that. So this brings us to the end of the closing ceremony, and we